हो सकता है थोड़ा दूर हटाना पड़े, दो वाले उसमें रहेगा तो लेकिन
Okay, let's start, Dr. Vivek. We are late.
Countdown.
हो गया ना countdown? करो.
Okay.
We
So
are
good
going
evening.
live in 3, 2, 1. We are live now.
Okay.
Okay. Good evening, everyone, and welcome to Symbiosis Series Webinar 3. That has been brought to you by Foxy Public Awareness Committee in association with the Bhopal OBGY Society and the Bhopal Menopause Society. And the webinar is Everything About PCOS. And let me have the privilege to introduce you, Dr. Monica Singh, who is the Honorable Secretary, Madhya Pradesh Chapter ISAR, Vice President Bhopal Obstetrics and Gynecology Society, Vice President Bhopal Menopause Society, Organizing Secretary 27th Annual ISAR Conference 23 Bhopal. She is the co-convener of ISAR Perfection Series and founder and convener of Foxy Symbiosis webinar series. Over to you, ma'am.
Thank you. Thank you, Dr. Vivek. And I thank INTAS for giving us platform to conduct the third episode of Foxy Symbiosis Series with the Public Awareness Committee of Foxy. Can we have the ICOG point slide? Number 1 slide. Yeah. So I'm very honored to welcome you all. And here, Foxy Public Awareness Committee, chaired by Dr. Priyankur Roy, a very dear friend, Dr. Bhopal Obstetrics Society and Bhopal Menopause Society. They are collaborating together. In the next 3 hours, we will be discussing everything about PCOS as the heading of the webinar is stating. And with great happiness, I declare 3 ICOG points which have been granted to our webinar, whoever is watching, and they will also be getting an e-certificate from this webinar committee within a week. So at the outset, I would like to thank the Foxy office bearers, our respected President, Dr. Rishikesh Pai, our Honorary Secretary General, Dr. Madhuri Patel Madam, Vice President Foxy, Dr. Alka Pandey Madam, and Chairperson Public Awareness Committee, Dr. Priyankur Roy, for giving us this opportunity. Nobody has to think anything about Dr. Rishikesh Pai. He's such a star in the galaxy of gynecologists in India. And I will always thank Dr. Pai from the bottom of my heart for making Foxy what it is today. Dr. Madhuri Patel is again a very dear senior to us. Every time she meets us, she is such a humble and a brilliant person to talk to. She makes everybody, every society of India feel as if we are a part of her. So I thank Madam for giving us this opportunity. Next, I would like to welcome Dr. Alka Pandey. She is Vice President Foxy, Professor Department of OBGY, Narayan Medical College, Saharsa, ex-Associate Professor, Department of OBGY, PMCH, Patna. She is the Vice President of Foxy till 2024, Organizing Chairperson of Foxy Vice President Conference in 2023, Member of Governing Council ICOG, Chairperson Practical Obstetric Committee Foxy 15 to 70, National Corresponding Editor of Jogi 17 to 20 and 20 to 23, President of Patna OBGY Society 12 to 14, Joint Organizing Secretary of 57th AICOG in 2014, Organizing Chairperson of the 14th PoxCon 2014, and she has been awarded the Asian Healthcare Summit Award of Best Gynecologist of Bihar in 2021. Thank you, Madam. And it is with great happiness I introduce my dear friend, Dr. Priyankur Roy. He has done a brilliant job in his committee. He's also the Assistant Professor of Lord Buddha Koshi Medical College Hospital, Saharsa, and Consultant in Fertility Gynec Endoscopy at Roy's Hospital and IVF Center, Siliguri. At present, he is chairing the Public Awareness Committee of Foxy. He has recently been given the post of President of the International Society of Watog, of which we are very proud because it is a very huge achievement. He's also the Managing Committee member of ISAR Bengal, Joint Secretary of Siliguri OBGY Society, Gestosis Society of India, Organizing Secretary of East Zone Yuva Foxy 2020, and International Watog Conference of 2021. He is a gold medalist, has been invited faculty in several national and international conferences, authored several chapters, written books, given articles in journals, and received so many awards, as you can read: the Corion Award, Foxy Future Award, S.S. Ratnam Award, Kamini Rao Orator Award, Shanti Yadav Award, Sun Traveling Fellowship, Nimish Shelat Award, and Kumud Tamaskar Research Award. We are so proud to have you here, Dr. Priyankur. From Bhopal Ops Gynae Society, this webinar would not have been possible without the support of our dear President, Dr. Anita Srivastav Madam, and my dear Secretary, Dr. Shabana Sultan. They are always there to promote our academic ventures and bring Bhopal out in the Indian map. Dr. Anita Srivastav is President of Ops Gynae Society till 2025. She is a postgraduate from NSCB Jabalpur and a resident post-PG residency from GMC Bhopal. She's at present working as assistant professor at CMCH Bhopal. She has held the various executive posts in the Ops and Gynae Society of Bhopal and has been trained in advanced gynec laparoscopic surgeries. She is a senior consultant at Chirayu Health and Medical Private Limited, Bhopal, with special interest in routine obstetrics, teaching, high-risk pregnancies, counseling, adolescent health, and cosmetic gynecology. We welcome you, madam. Dr. Shabana Sultan is esteemed Honorable Secretary of Bhopal Ops Gynae Society. She is also a keen academician who has presented several papers in national conferences. In international journals, she's written her articles. She is member of the esteemed team of PPH Bundle along with Sevagram. She has held the post of Joint Secretary Bhopal Ops Gynae Society, past Treasurer, present Secretary, and she's also the executive member of MP ISAR. She has done various international projects along with Harvard University. Her special interest is in gynae onco and high-risk pregnancy, and she's the master trainer of cervical screening program. We welcome you, Dr. Shabana. From Bhopal Menopause Society, we have our president, Dr. Shashi Srivastav Madam, and our very active secretary, Dr. Shraddha Agarwal, who is very passionate about her social work and social reforms. Can we have the CV, please? Dr. Shashi Srivastav is a very respected, very dear senior. She's director of a very renowned nursing home of Bhopal, Saurabh Nursing Home. She is heading Bhopal Menopause Society in a very dynamic way. She is life member of the society, PCOS Society in Foxy. Her special areas of interest are recurrent pregnancy loss, ultrasound, and PCOS, about which the webinar is today. Next, I would like to talk about Dr. Shraddha Agarwal. Do we have a CV? Yeah. Madam is a senior gynecologist of Bhopal. She has devoted her whole life to the government sector, and she has done a brilliant job as a laparoscopic LTT surgeon. Plus, I told you she's very much interested in social work, tree plantations, care of environment. She has done almost 40,000 LTTs, which must be a landmark. Faculty CPS course master trainer, published many papers in indexed journals. She has held the post of Secretary Bhopal Menopause. She is the Secretary Bhopal Menopause Society and held the post of former President Foxy Bhopal, former Secretary Ampox. She has been the organizing secretary of All India Adolescent and Juvenile Gynecology and organizing secretary of the West Zone Yuva Congress, which was hugely successful. Welcome you, madam. Next, it's my honor to welcome our chief guest for today, Dr. Bhaskar Pal. All of us who attended last AICOG in Kolkata know what a brilliant team and what a huge amount of applause he got for the AICOG, which was a very, very successful event. The biggest conclave of gynecologists in India was held in Kolkata under his flagship guidance. Can I have the CV of Dr. Bhaskar Pal, please? Sir is alumnus from Mumbai. He's a senior consultant gynecologist at Apollo Multispeciality Hospital, Kolkata. He is the chair of AICC RCOG, immediate past president of IAGE, Foxy representative to CEFOC 21 to 23, chair of organizing committee AICOG 23 in Kolkata, immediate past president of Bengal Ops Gynae Society, vice president of Foxy in 2017. Sir is examiner MRCOG and author of over 35 papers and book chapters. And Sir is going for elections as Foxy president. We wish him all the luck. As chief guest, I invite Dr. Arun M. Barua. Sir is a very accomplished senior gynecologist from Apollo Fertility, Guwahati, Assam. Chairperson of the Northeast IAGE and founder chairperson of Northeast ISAR, past president of Dibrugarh Obskyny Society, senior vice president of IMA Assam State Branch, vice president east of SOFC, and a very active Rotarian since 25 years. Welcome, sir. It's my extreme privilege and with great happiness I introduce from my own Madhya Pradesh, Jabalpur, Dr. Manik Panse. She is the alumnus of the very prestigious and old medical college of MP, NSCB Medical College, and she is director of Anant Multi-Speciality Hospital there. She is at present heading Jabalpur Obskyny Society till 24. She is lecturer at Dayanand Medical College, Ludhiana, with 30 years of experience in obstetrics and gynecology and special area of interest in RP and high-risk pregnancy. Madam is a life member of IMA, IMS, ex-member Executive Council RDVB, founder member and PPIB IW Club Jabalpur South, actively involved in social awareness drives, active member of Virat Hospice for terminally ill cancer patients, which is such a noble work. Welcome, ma'am. Can we have a few words? Can we have a few words from Dr. Purnima? Has chief guest joined?
Ma'am, Haskell sir has not joined.
Manik ma'am, Manik ma'am. Manik ma'am.
Hello.
Yeah, Manik ma'am was with me in the morning. I think she must have. Have you checked?
I have joined.
Yes, ma'am. Yes, ma'am.
Can you see? Can you hear me?
Ma'am, we can hear you, but we can't see you right now.
I don't know why. Can I see you?
But ma'am, we can hear you very clearly.
Okay, then I speak.
You are this. Your name is coming as Samsung SM. The phone you are logged in.
My iTab.
जो नहीं start किया.
मैम उसमें आपको शायद अपना वीडियो ऑन आई थिंक वीडियो ऑन वाला you have to
I have started with my video.
Ma'am, now you're seen. Now you're seen.
I'm seen now.
You have to reverse the camera. You have to reverse the camera.
Sure.
Camera is reversed, I think, ma'am.
Okay.
Yes, ma'am. Now we can see you. We can see you, ma'am.
Okay. Well, good evening to all. I'm very thankful to Monica for making me a part of this very interesting topic, and I'm very much interested in doing awareness program for PCOS. This is most prevalent. We all know worldwide the percentage is 6 to 20%, but in India it is slightly more. Maybe because of genetics or some endocrine system or sedentary lifestyle. We hand over the two-wheelers to our 16-year-old daughter without thinking that she'll gain weight. We ask them not to work in kitchen. I think kitchen is the very good exercise the girls can do. Then diet, we give you all wrong kind of diet. और दुबली है तो बोलते हैं दुबली है, मोटी है तो बोलते हैं मोटी है. So it is very commonly talked, but very less understood, and it is very elusive. I should say that we are talking a lot. When I did my PG, it was a small note we used to have of 5 marks, and now volumes and volumes have been written. Still the problem is increasing, and people know a lot because of Google help groups and everything, but somewhere we are not doing the awareness properly. We should tell people about reducing weight, having good exercise schedule throughout the week, and we should avoid all white things like cheese, maida, fast food, especially to the girls, because these girls are future mothers. And Monica will agree with me that infertility is very common in these people. So I think this webinar is going to help. They are going to make us wiser. Thank you, Monica, for making me part of this. And thank you, Dr. Singh, I can see you
Yes, ma'am.
properly.
Thank you, ma'am. Thank you, ma'am. Thank you, ma'am.
Okay,
Thank you, ma'am.
okay. Nice, nice. I have a photograph
Yes, ma'am.
when
Yes,
I
ma'am.
was in Indore.
Yes, ma'am.
And we
Yes,
are
ma'am.
so honored. Out of the guest of honor and two chief guests, you are the only one present. So you are everything to us because Dr. Bhaskar Pal was very busy in his OT. He said,
I know.
Monica, you can call me if possible. Purnima, you can give him a call. Sir said he will join on speaker. Give us his.
मोनिका आपने बुलाया और हम चले आए.
Yes, ma'am. मैडम जबलपुर तो हमारा घर है मैम. जबलपुर तो हमारा घर है और मैडम अनीता श्रीवास्तव मैडम और हमने मैडम पीजी वहीं से किए मैडम 93 से 96.
मैंने
यस
तो
मैम, वो
पूरा
हमारा
ही
होम टाउन है. अनीता मैम बोलिए.
MBBS MS and birth place भी जबलपुर है.
क्या
देखिए
बात
मैम.
है.
Dr. Anita, if I may say, Dr. Aradhana Singh, I'm also from Jabalpur MBBS.
Yeah.
Yeah.
Monica ma'am, I have spoken to Bhaskar sir. He will join by 5:15, 5:30 ma'am.
Okay.
Okay.
I'm sorry. So, Purnima, you talk to sir?
मैम भास्कर सर से
Join
भी
at
बात
5:15.
Okay.
Ma'am, I have spoken to him.
Okay, Monica.
Ma'am,
Right.
at 5:15, 5:30, sir will log in, ma'am.
Right. So let's
Yes, ma'am.
let's now introduce my MOCs. And I know MOCs will introduce Dr. Monica Umbaran and Dr. Shatabdi Dey, but I must speak a word about them that along with Priyankur was very busy, but these are the right and the left arms of Priyankur who have right from day one pitched in like anything. In fact, I was feeling guilty, that they are doing all the work and I'm not doing anything. But they are so sweet, both of them, always available, always eager to help. And you people are doing such a tremendous work all over India that I'm very proud to be associated with you, Monica and Shatabdi. Thank you so much. To hand over the program, I have my MOC, Dr. Shabana Sultan. I have already introduced her. She is the Honorary Secretary of Bhopal Obsgyne Society. And my MOC, the other MOC is Dr. Purnima Tiwari. Can I have a CV, Vivek? Yeah. Dr. Purnima Tiwari is a very dear junior to me. She is a very accomplished gynecologist with keen interest in IVF and reproductive medicine. She is working in Apollo Sage Hospital, Bhopal, alumnus of MAMC Delhi, been awarded several fellowships, and she is a member of RCOG, got several prizes. She's a prolific reader, academician, and she's a program coordinator for not only the Symbiosis series, but also the ISAR Perfection series, which is a flagship series academic venture of ISAR under the chairmanship of Dr. Nandita Palshetkar and the kind patronage of our president-elect, Dr. Sunita Tandalwadkar, madam. So I hand over the program to you, Shabana. Please carry on.
Yes, Deep. Good evening, everyone. Actually, this Symbiosis Series 3, the whole credit of this idea goes to Dr. Monica Singh, dear friend, and Dr. Randir Singh, sir. And I'm very much delighted to introduce Dr. Randir Singh, sir, who is MD LLB Organizing Chairperson, 26th Annual SR 2023, ASHRAE Certified Embryologist, Director, Bhopal Fertility Endoscopy Center. Professor is working as a professor in Allen Medical College and JK Hospital, Bhopal. Immediate past Chairperson MPSR, President MP Nursing Home Association. He's very active in the whole association, Organizing Secretary SAR 2016 and 2018. And he has published so many papers and presented so many international and national conference papers, whom he awarded with the Best Poster Award in Inspired Indonesia 2016 and Best Oral Award in IFS 2016 New Delhi. So I'm very much delighted to introduce my dear Randir Singh, sir. And again, I'm delighted to introduce Dr. Monica Umbaran. Actually, she is actively working to make this Symbiosis series successful. So Dr. Monica is MD, DGO, FCPC, DFM, FICOG, LLB, She is working as a consultant obstetric gynecologist at Mangala Nursing Home and Atharva Fertility Center. She is committee chairperson of public awareness, MOGS 2022-24, web coordinator of MOGS 1820, youth coordinator MOGS 2022, executive member of public awareness committee 2019-22, executive member of ISOPAP 2019-2022, treasurer IMA 21-22, Solapur obstetric treasurer 2015-16, clinical secretary 2018-19, honorary secretary 2019-20, and executive member since 2014. And she is very much instrumental in designing website and SOGS app. So I welcome Dr. Monica and Dr. Shatabdi. They also work actively to make this Symbiosis series successful. Thank you so much, Shatabdi. She is MSDNB Fellowship in Reproductive Medicine. She is a young consultant working in Nova IVF Fertility Siliguri. She is convener for Public Awareness Committee, FOXY. Thank you. So we move forward to start our session 1, and there's a little bit change in it because Dr. Priyanku Roy is busy with his patient. So a little bit change in the speaker, that in the first session, I'm inviting Dr. Anita Shrivastava to talk on tackling PCOS in adolescent. And for chairing this session, I'm inviting Dr. Aradhana Singh and Dr. Rajkumari Praneshwari Devi. Can I have the CVs? Dr. Aradhana Singh is MBBS MS FICOG, FICMCH, FGL, PGDS, Fellowship in Gynec Laparoscopy, President Noida Obstetric Gynecological Society, Additional Director OB-GYN, Fortis Hospital Noida, Organizing Secretary North Yuva Foxy 2019, Secretary Noida OBS-GYN Society 2013-2015, Chairperson Sexual Reproductive Health Committee, Executive Member Endocrinological Committee, former Executive Member of Adolescent Committee of FOXY, Joint Treasurer of Noida OB-GYN Society in 2011 and 13, received Award of Young Talent Contribution to NOGS in 2016. Our special interest is high-risk pregnancy, endoscopy, gynec endocrinology, adolescent gynecology, colposcopy, gynec ultrasonography, menstrual disorders, hygiene management, and menopausal gynecology. So welcome Dr. Aradhana for chairing session 1. And the next chairperson is Dr. Rajkumari Praneshwari Devi. She is MS, DGO, FIAOG, FICOG, Professor Department of OB-GYN, RIMS, MPhal, Secretary IOGS, immediate past, external internal examiner in different medical colleges. She has 42 international and national paper publication. She got highest marks in 12th examination in state of Manipur and second highest in MBBS exam, highest biochemistry marks in OB-GYN. Attended presented paper in World FIGO conferences, attended the last 10-year AICOG conferences. I welcome you, Dr. Rajkumari Praneshwari Devi, for chairing this session. And kindly introduce our speaker. I request one of the chairperson to kindly introduce our speaker, Dr. Anita Shrivastava.
Thank you, Dr. Shabana, for the kind introduction. So first of all, I would like to thank the team of Symbiosis Series, Public Awareness Committee team, Bhopal OBGY Society team. Thank you for making us part. And it is actually very important topic, PCOS, which have been taken in this the webinar. So my first speaker is Dr. Anita Shrivastava, and I'm proud to reintroduce her. She's the president of OBG Society of Bhopal 23-25 and a postgraduate from Government Medical College Jabalpur. So it is the same my college also. So I'm so happy to be amongst all of you. Dr. Randhir also is from Jabalpur. So a very warm good afternoon to all of you. She is also assistant professor at CMCH Bhopal and past vice president of and secretary, joint secretary OBGY Society of Bhopal, and presently senior consultant at Chirayu Health and Medical Private Limited Bhopal. She has got a special interest in routine ops, high-risk pregnancy, adolescent health and cosmetic gynecology. And she is going to take Dr. Priyankur's talk, and that is on the PCOS.
I'll take my.
Please welcome. Yeah, revisit.
No, she will take her talk only, Dr. Aradhana.
Yeah. Acha, she will take her talk only. Okay. Welcome, Dr. Anita.
Thank you, doctor, for nice introduction. There is a change in the time, but my topic will remain the same.
Oh, say, okay,
Okay.
fine.
I'll be talking about PCOS in adolescent. Adolescent is my topic of interest,
Sure.
and I was very much interested in. Is my screen visible?
No,
Yes,
Didi.
ma'am. PPTs are not.
We can see the blank screen Zoom, but we cannot
But-
see your PPT. You have to slide
Okay.
share. Have you shared the screen, Didi?
एक मिनट
कर लीजिए आप.
शेयर आ गया.
मैम आपके नीचे में पावर पॉइंट का एक आइकॉन है, उसको क्लिक कर लीजिए, खुल जाएगा.
वो दिख रहा है मेरे को.
हाँ, उसको क्लिक कर लीजिए, आ जाएगा.
आया?
Yes,
Yes,
it's
yes,
coming
yes.
now. Yes.
स्लाइड चेंज हो रहा है. केवल नाम ही आ रहा है.
First slide we can see, Didi.
You have
हाँ.
to, yeah,
Right.
first slide we can see.
Title
Yes.
slide we can see.
हाँ.
You must be seeing the arrows now to change. Yeah.
Okay. Good evening, everybody. Thank you, Monica, for giving me the chance and associating with Bhopal Obs and Gynec Society for this Symbiosis series. We'll be very happy to be with you and promote you as well as our society in future. Okay. This
Okay.
topic is very important for all of us since polycystic ovarian disease or polycystic ovarian syndrome is a common in female reproductive disorder that often manifests during adolescence and is associated with disruption in the health related quality of the life. So polycystic ovarian syndrome accounts for the vast majority of anovulatory symptoms and hyperandrogenism in adolescence. The PCOS is a complex and heterogeneous familial disorder. It affects about 5 to 15% of the females of reproductive age. It is prevalent in 1.4% of the girls between 15 to 19 years if we use the NIH criteria for diagnosis PCOS. PCOS is most common endocrine abnormality in the reproductive aged women, and it is characterized by chronic anovulation, hyperandrogenism, and polycystic ovaries. The classical syndrome, originally described by Steen Leventhan as an association of amenorrhea with polycystic ovaries and variably hirsudism and obesity. So it is very important for us to go through each and every point of PCOS, but I'll restrict myself to the adolescent life. It is unclear. The etiopathogenesis is unclear and may be unknown in spite of a basic and clinical research and various type of paper presentation. In adolescents, the PCOS, there is an imbalance in steroidogenesis, which causes exaggerated LH response, causing excess of androgen production and inadequate FSH, which further leads to there is inadequate conversion of androgen to estradiol with follicular arrest. And there is insulin resistance and hyperandrogenemia, which is more common in overweight and obese girls. There is a change in insulin and androgen metabolism, and it appears to be interrelated as increase in androgen reduced insulin sensitivity and insulin elevation may potentiate the androgen secretion in the fat tissue. The insulin also augments the ovarian response to LH and enhances the deregulated LH secretion from the pituitary gland. And it is also said that PCOS may be genetically predisposed, but the epigenetic factor and the environmental factor also affects the development of the PCOS. So PCOS may be due to genetics or may be recognized as menstrual irregularity, may have cutaneous or the hyperandrogenism, obesity and insulin resistance, and it may show polycystic ovaries. So spatial relation of PCOS and adolescence. There is physiological why we have to differentiate? Because there is physiological anovulation and anovulatory bleeding due to immature hypothalamic pituitary ovarian adrenal axis in adolescent girls. There is a hyperinsulinemia is very common in healthy adolescents. Weight gain may be present due to other reason also. The skin changes and acne is very common and it may be a physiological one. Psychological stress may be present and imaging by transabdominal sonography gives us suboptimal results. And the thyroid disorders may be present. So we have to tackle the adolescent with great care. Although early identification and management of the adolescents with PCOS can prevent long-term reproductive, cardiometabolic, and emotional consequences associated with PCOS in future life. So we should never overdiagnose PCOS, neither we should underdiagnose it, because overdiagnosis can influence an adolescent quality of life and create an early and unwarranted anxiety for the future fertility. What is the importance? The importance may be that there is a risk of chronic anovulation, there is a risk of infertility, cardiometabolic disorders including obesity, type 2 diabetes mellitus, dyslipidemia, metabolic syndrome, hypertension, risk factor for the cardiovascular diseases may be present, and there will be a development of endometrial hyperplasia or carcinoma may be associated with the patients with PCOS. So, how to diagnose? These criteria are somewhat controversial when used for adolescents. For example, the level of AMH to define PCOS is not yet established. What is the level of AMH should be in adult and what is the AMH level should be in adolescent girls. So the criteria are somewhat controversial as many features like hirsutism, acne, and menstrual irregularity may be common both in physiological event and in the pathological event. Various institutes have given various criteria to define it. National Institute of Health criteria, there is evidence of anovulation or oligoovulation, evidence of clinical or biochemical hyperandrogenism or either of them. There will be clinical criteria like hirsutism, acne, or male pattern blanding, biochemical high serum androgen concentration. The Rotterdam criteria is there. There is androgen excess and PCOS society criteria. There is Amsterdam criteria, which suggests all the three elements should be present in teenagers, diagnosing it as PCOS in adolescents, since there is not enough evidence to confirm the NIH criteria for adolescent. Pediatric Endocrine Society recommended the criteria of persistent hyperandrogenism and oligo and ovulatory cycle based on suitable standard. The diagnostic criteria of PCOS in adolescent, the Sultan and Perez says at least 4 out of 5 should be present to diagnose it as PCOS. The 5 criteria are the oligomenorrhea or amenorrhea. 2 years after menarche. In initial days, oligomenorrhea or amenorrhea is very common physiologically also. The sign of clinical hyperandrogenism, such as persistent acne or severe hirsutism. Increased plasma testosterone more than 50 nanogram per deciliter or increased LH-FSH ratio. Insulin resistance and hyperinsulinemia evident as acanthosis nigricans, abdominal obesity, glucose intolerance. And the fifth is polycystic ovaries on ultrasound scan showing enlarged ovaries and peripheral microcysts and increased stroma. The diagnostic criteria of PCOS in adolescent by Bruni et al. And Largo et al. Are also present. So it is recommended in the following scenarios that girls whom to evaluate. The girls with sole finding of moderate to severe hirsutism should be investigated for PCOS or hirsutism equivalent to including persistent acne or pattern of alopecia. The girls with mild hirsutism or obesity with any other feature of PCOS like menstrual abnormalities should also be investigated. Adolescent girls with menstrual irregularities which persistent for more than 2 years or who have severe dysfunctional uterine bleeding. Adolescent girls with intractable obesity, whether or not hirsutism is present, hirsutism equivalents to, or the menstrual irregularities are present. In menstrual irregularities, chronic ovulation increases the risk of development of endometrial hyperplasia, which is associated with endometrial cancer. So they should always be investigated. And if the bleedings is irregular or heavy, they may land up in anemia. Criteria for, what is the criteria for oligo and ovulation? Menstrual interval less than 20 days or more than 45 days in an individual for 2 or more years after menarche are evidence of oligo and ovulation. A menstrual interval of more than 90 days is unusual, even within the first year after menarche, and requires further investigation regardless of year of menarche. Lack of onset of menses by 15 years or 2 to 3 years after menarche, regardless of chronological age, warrants further evaluation and consideration, such as PCOS. The spectrum is very wide. So, we have to look after the menstrual irregularities as well as hyperandrogenism. The androgen panel consists of testosterone total and free, DHA. Interpretation of these levels are difficult because the source of androgens are many. Plasma and testosterone level have pulsatile and diurnal or the cyclical changes. A total testosterone level more than 90 deciliter per microgram per deciliter is considered as androgen excess. For free testosterone, there is no uniform lab standard for adolescent girls. So how should we look after hyperandrogenism? This is a very busy slide, but I'll tell you. First, we go for pelvic ultrasound. In young adolescents, up to 8 years of menarche, we usually prefer transabdominal sonography. And if there is abnormality other than polycystic ovary, then the tumors of the ovary or the adrenal glands, ovotesticular dystrophy, or functional hyperandrogenism of pregnancy, unrelated gynecological condition, then we will leave this group. If the ovaries are polycystic, then we have to look about it if it is classical PCOS or another endocrinopathies. If the ovaries are normal, it is non-classical PCOS, and we have to search for another endocrinopathy. The endocrine screening workup is done. Prolactin, TSH, if it is abnormal, prolactin excess, thyroid dysfunction, or acromegaly is to be searched. If the cortisol is elevated, you have to look after Cushing syndrome or cortisol resistance. If 17 DHEAS EAS is elevated, then we have to look for adrenal tumor. If the screening tests are normal, then only we can mark it as PCOS. So it is a diagnosis of exclusion. How to go about the insulin resistance. This is the one of the common things which is said to be the reason for PCOS. Hyperinsulinemia is very common in healthy adolescents. Insulin sensitivity decreases by 50% with increase in insulin, which returns to pre-pubertal level in childhood. But both insulin resistance and hyperinsulinemia are more severe in adolescents with PCOS as compared to the general population. The insulin stimulates the ovarian theca cell synthesis and androgens, and it inhibits the hepatic production of HSBC. Increased free androgen level, perpetuating the pathophysiology of PCOS. The insulin resistance promotes the release of non-esterified fatty acids from the liver and adipose tissue due to decreased lipoprotein lipase activity, which contributes to the dyslipidemia. So, if there is insulin resistance in adolescent, although the insulin resistance and obesity are usually associated with PCOS and exacerbate hyperandrogenism and metabolic manifestation of PCOS in adolescent. These metabolic disorders should not be used as the diagnostic criteria for PCOS in adolescent girls. However, in the presence of obesity or metabolic syndrome or manifestation of insulin resistance, physician should be considered the possibility of PCOS and it related comorbidities. So he or she should investigate the patient further. What are the clinical recommendation of 2017? A thorough medical history is to be taken, physical examination and appropriate lab assessment are to be done to provide the information necessary to exclude the other disorders associated with androgen excess. Mind you, PCOS is always a diagnosis of exclusion. Insulin resistance and hyperinsulinemia can be considered as indication to investigate and treat potential comorbidities. However, according to the PCOS criteria, its diagnosis needs exclusion. Non-classical adrenal hyperplasia is most important disorder in the differential diagnosis of PCOS of all guidelines recommended and screening this order. The screening of hypothyroidism strongly recommended because the hypothyroidism can result in irregular menstrual cycles and thickening of the hair. And it is now find out to be a very common cause or very common pathology present in youngsters. Guidelines also support that the screening of all patients of hyperandrogenism for hyperprolactinemia, since it is reported in 16% of the teenage females. And most important, AMH level should not be used to characterize PCOS in adolescents. What is the sonography criteria? The sonography criteria shows the international consensus criteria define that the polycystic ovary on the base of either excessive size or follicle number or both in the absence of dominant follicle, that is the more than 1 centimeter size follicle or a corpus luteum. Using these criteria, a polycystic ovary can be identified by ultrasonography in about 75% of the PCOS women. And nowadays, it is considered that when the machines are very when the machines are very sophisticated and good machines are there, the number of follicles which are to be present should be more than 20. So the volume of the ovary normally should be more to diagnose PCOS should be more than 10 mm, more than 12 to 20 follicles should be present. The multifollicular ovaries are normal in adolescents. So the other, if I want to compile all the hormones, I can say we should test for FSH, LH and estradiol, total and free testosterone, serum hormone binding globulin, DHEAS, alpha hydroxyprogesterone, TSH, prolactin, and for metabolic parameters, fasting blood sugar, fasting serum insulin, and lipid profile, along with sonography is to be done. So we have to exclude pregnancy in adolescent. It is nowadays very common thing. If the patient comes with amenorrhea, we have to, even if she is very young, we should test for pregnancy. The another thing is adrenal tumor. It is rare, but may be indolent and mimic PCOS. Advised to specifically screen USG image for adrenal gland. In atypical cases, CT scan may be indicated. Goiter, galactorrhea, thyroid and prolactin disorder. In Cushing syndrome, central fat distribution is there, stria and easy bruisability is there. The anabolic steroids, especially the sports person, may be using the anabolic steroids. Free and total testosterone and DHEAs are routinely measured and assessed for the contribution of the ovarian and adrenal androgens, considered possibly the adrenal or the ovarian tumor. If the late congenital adrenal hyperplasia is suspected, serum FSH can be measured to ensure that the ovary is functioning. FSH-LH ratio is nowadays not considered for that. AMH should not be used as a diagnostic criteria. The fasting blood sugar should be more than 100. The high density lipoprotein should be less than 40. Triglyceride should be more than 110. The waist circumference should be more than 90 percentile for the age or the sex. The blood pressure should be 90 percentile for the age or the sex of that patient. Or adolescent with PCOS are at increasing risk of hypertension as compared to the other age group. The blood pressure should be measured at every visit. The hypertension in the patient with PCOS conferred a high risk factor for the cardiovascular disorders. There is a greater risk if associated with glucose intolerance. The presence of 3 out of 5 criteria is suggestive of metabolic syndromes. So, how to manage? The management of the PCOS depends in adolescent, especially in adolescent, depends upon the clinical manifestation. So we will have the roadmap how to manage. We have to manage the clinical problem. We have to control the menstrual irregularity and the hirsutism. The approach to the treatment for the adolescent are primarily directed as major clinical manifestation and complaints. The lifestyle modification. It is the first line of non-pharmacological treatment for adolescent PCOS, and it is the most important thing how to manage it. The pharmacological agents are used, for example, combined oral contraceptives, metformin, separately or combined, or nutrition adjuvants, exercise. So what to do in lifestyle modification? It has to be done for the lifetime. It is not to be done for a year or two till the symptoms are controlled. We have to teach the patient or adolescent girl as well as the family members that it should be done for the lifetime. So what to be done? Minimum 30 minutes of moderate or invasive extra exercise twice a week. The diet should contain high fibers, complex carbohydrate diet, and simple carbohydrate and fat should be very low. It should be low in saturated fat, low GI index containing things, low sugar, high fiber, high in essential fatty acid, high in antioxidant food. The timing of the meal is also very important. The major meal should be at breakfast and least at the dinner. And nowadays, intermittent fasting of 16 and 8 or 20 and 18 and 6 is also followed. And it is given a good results. Protein consumption is preferred at breakfast meal. Hydrogenated oil and packaged food is to be totally excluded. And cessation of smoking is avoided. As Dr. Manik said, we should avoid all the white things like white sugar, white maida, processed food, and fast food. Now coming to combined oral contraceptive pills. Regulating the menstruation and reducing the manifestation of hyperandrogenism is the priority for any adolescent in PCOS. The combined oral contraceptives are the first line of treatment and mainstay of endocrine treatment for adolescent girls for PCOS. It corrects the menstrual irregularities. as well as it corrects the dermatological manifestation of PCOS, and it corrects the base of PCOS. I can explain it like that. The mode of action is it regulates the menstrual cycle with dependability and blocks the activity of plasma androgen, mainly feed testosterone, by inhibiting the ovarian function. They also act by increasing serum hormone binding globulin level and lower DHEA sulfate concentration. So, androgen level are quickly normalized. It reduces the excessive menstrual bleeding and help in correction of anemia in anemic adolescents. Combined oral contraceptives may be of different forms. For example, it contains 30 micrograms of ethylene estradiol with 3 milligram of drospirenone. It is more effective if the patient has an increased BMI. If the patient has more of androgenic features like hirsutism and acne, we should use cyproterone acetate with ethylene estradiol. Mild anti-mineral corticoid activity or mild anti-androgenic properties minimize the fluid retention and androgenic adverse effect. The different COCs have almost similar effect on the hormonal profile of the patient. So the COC with cyproterone acetate has more effect on hirsutism. So we have to use in those patients. Keep an eye on usual contraindication of COCs. COCs contain less in androgenic progestin, may have less deleterious effect on the insulin resistance and lipid profile. If we want to use only progestin, so these progestin will normalize the cycle, but they will not change the hormonal profile of that patient. For normalizing the cycle or bringing the cycle back, we can use medroxyprogesterone acetate, 10 milligram BD for 5 days or 10 milligram OD for 10 days in the luteal phase. And it has an advantage of regular menstrual cyclicity, but it does not aid in restoring the androgen level. So it is not beneficial in girls with excess hair or hyperandrogenism. The perimenarchal girl who respond adequately to progestin may be maintained at about 6-week cycle interval for aiding the detection of spontaneous menses. The adverse effects are mood disturbance, bloating, breast soreness, etc. Heavy menstrual bleeding occasionally occurs with the only progesterone treatment, and the COCs may be given to control these symptoms. Now coming to metformin. It is still very controversial. It is said that we have to go for glucose tolerance test, and if there is intolerance and insulin resistance, then only we should use it. But it is used very widely for PCOS control. Using metformin, however, is commonly being used in young females and adolescents with PCOS as the first line of medication with or without COCs or any anti-androgen. Metformin appears to be most effective in managing adolescent as it controls appetite and augment weight loss. We have to start with 500 milligram once daily with evening meal, and we can increase up to 500 milligram 3 times in a day. In lean adolescent, low doses such as 850 milligram in a sustained release fat pattern may be useful. Whereas in obese and overweight adolescent, dose should be increased to 1.5 to 2 grams. Anti-androgens. Anti-androgen treatment, what should we do? It is recommended that for hirsutism, when 6 to 9 months of hormone therapy is given with combined oral contraceptive pill, we have no response on hirsutism or acne or like that, then we have to add anti-androgens. Anti-androgens improves hirsutism by decreasing the androgen production and binding the androgen receptor in the target tissue. The androgen receptor blocker like spironolactone or flutamide is there. The alpha reductase inhibitor like finasteride are not available in many countries. Spironolactone is most commonly used as anti-androgen therapy in adolescent PCOS. There is a risk of teratogenicity in case of pregnancy, as well as to control menstrual cycle. It is recommended to prescribe spironolactone with combined oral contraceptive pills or ethylene estradiol. Flutamide is not available in many countries due to high risk of hepatotoxicity. A main concern of use of androgen in adolescent is effect on BMD. However, there is a paucity of literature to use these medication in adolescent population. Now coming to the food supplements, myoinositol and D-chiro-inositol. There are studies which says these two stereoisomers of inositol are easily found in plant-based food source, and they are considered as insulin sensitizers. Now, many studies are available for their use. The N-acetylcysteine has been studied as well as compared with metformin as insulin sensitizer. And in some studies, it has been shown that there is improvement in metabolic and hormonal profile of the PCOS young lady. The DHA, red yeast, berberine, curcumin are all present in the market, which are used, but further studies are to be done to establish them as a treatment for PCOS. Prebiotic and probiotic are being given in the studies and the role of the management of PCOS. And there is a dogma theory for that. These prebiotic or the gut microflora, it is proposed that this causes the change in the microflora of the patient. And these microbial agents it has proved that poor diet result in disturbed bowel bacterial flora causing mucosal damage and increased gut permeability. It allows the lipopolysaccharides from the gram-negative colonic bacteria into the systemic circulation, resulting in activation of immune system. This immune system releases cytokinins and which interferes with the intercellular insulin receptor function and which drives up the serum insulin level and which in turn affects the ovary to increase androgen production and interferes with the normal follicular function. So thus, this dogma theory is a emerging concept. What are the supportive treatment in the lifestyle management? The first supportive treatment is the counseling. The counseling done by the physician, the counseling done by the family physician, by the gynecologist, by the mother, and by the family members make a very great difference in the life of a young adolescent. The mood disturbance are very common in these girls. The propensity of obesity and cosmetic concern may lead to poor self-esteem and depression. The adolescent perceive little control over many aspects of PCOS with menstrual irregularities and threat of infertility reported as most stressful and the least controllable aspect of PCOS. Attention to social, emotional, and vocational development is critically important. As an adjunct to treatment, listening to the adolescent friendly and cosmetically offering them some services, and it is very important. And we should not give the diet management plan to the young adult as a punishment, but as a normal change in their lifestyle. So my take home message is there should be early recognition so that we should get the opportunity for timely intervention and prevent the long-term reproductive, metabolic, psycho-emotional complication associated with PCOS. The clinician should re-evaluate all such patients with features of PCOS, avoid over or incorrect diagnosis using precise criteria suggested for this group only. Third, the appropriate therapeutic option for adolescent with PCOS should be recommended based on major clinical and manifestation and complaints. In addition to the asserting for associate comorbidity management, it should always include regular follow-up, regular visit, planned transition from adolescent to the adult care. Attention should be given to the both physical as well as the emotional health of the patient, because it affects the long term of any patient, and it is a part of a personalized management strategy which is very important for the overall longitudinal health outcome of the affected adolescent and emerging adult. In absence of definitive diagnosis, lack of approved therapy, positive lifestyle intervention should be encouraged. Thank you.
Hello. Hello. Thank you. First of all, thank you. Back Symbiosis. Hello. Can you listen? Can you listen?
You are audible, ma'am.
Thank you, especially Back Symbiosis with Bhopal of Sanagani Society on this precious to be included as a chairperson. This is wonderful webinar. And thank you, Dr. Anita Srivastava. So Dr. Anita has explained that we have already confusions to diagnose the adolescent PCOS. Nowadays is the era of internet. So many adolescents, they approach us that I'm suffering from PCOS. So it's very good that you have the exact criteria for diagnosis of the PCOS adolescents, so that we can convince, if we can really diagnose, not overdiagnose, underdiagnose, and we give accordingly the treatment. If they are not that fully developed, then we have to tell them to just do the lifestyle modification and all those things. So Anita Madam has highlighted so nicely how to differentiate from the real adolescent suffering from PCOS and those hormonal changes and then dietary imbalance. So thank you, Dr. Anita Srivastava, for highlighting the very important topic of this management of the PCOS in adolescents. Thank you, Anita Srivastava.
Thank you, ma'am. Thank you. Thank you for
Thank you so much, Dr. Anita Srivastava.
Thank you, Dr. Anita. Thank you.
And now we are very privileged. We have Dr. Bhaskar Pal, our chief guest, amongst us. Sir has joined. And I would request the support team, Dr. Vivek Sharma, to please put Sir's slide on the screen. Good evening, Dr. Bhaskar.
Good evening.
Good evening, sir.
Good evening.
Good evening, sir.
Despite your busy schedule and I think the whole day in the theater, you could join. And we can see you are still traveling, not reached home. But it means a lot to us that your blessings are with us today. Sir, we have you as the chief guest. We have our guest of honor, Dr. Manik Panse, and we would like to have a few words from you, sir.
Thank you very much. I am really honored to be invited as a chief guest to today's program, and I thank the Public Awareness Committee of FOXI, the Bhopal Obs and Gynae Society, and the Bhopal Menopause Society, and in particular, the Monica duo, Monica Umbardan and Monica Singh Chauhan, for calling me here. And I think public awareness is the key as far as PCOS is concerned, because adolescents are a difficult group to catch and very difficult group to manage. And it is very important that we make the society aware that what are the long-term effects of polycystic ovarian syndrome in terms of metabolic syndrome, in terms of fertility, etc. Also, the adolescents have to be handled with a bit of care. And as Dr. Anita Srivastava was speaking, that we do not want to impose a diet plan on them or don't want to push that as a punishment. Any decision that we make in terms of lifestyle modification, which is a key, should be a shared decision making. This is a wonderful speaker and a wonderful session and a star-studded lineup star-studded lineup with Dr. Priyanku Roy, Dr. Anita Srivastav, and Dr. Monica speaking, and Dr. Sneha and Dr. Basav Mukherjee moderating the panel with along with Dr. Sonia Malik as expert. And I'm very happy to be here among friends. I can see Dr. Supriya Jaiswal, Dr. Nivedita Datta, Dr. Aradhana Singh, Dr. Purnima from Bhopal, my dear friend Dr. Sneha, Dr. Priyanku, Dr. Randhir, Dr. Shabana, Dr. Shweta Mathur, and everyone else, Dr. Jaishankar Saha, Dr. Ankita, Dr. Shweta Kumari, Dr. Rajkumari Praneswari Devi, who I know by a different name. And I wish this program a great success. And I think the Public Awareness Committee is doing a great job, whether it comes to Save the Uterus, whether it comes to PCOS, whether it comes to cancer awareness. Please keep it up. And I'm really honored to be here. And thank you for inviting me.
Thank you.
Thank you, sir. Thank you, sir. And best wishes for your election, sir. Thank you, sir.
Thank you.
We wish you all the best for your further journey, sir, to the topmost post in Foxy.
Only I don't understand why people are being so formal. Nivedita, my younger sister, who calls me Bhaskar, here is writing that good afternoon, Bhaskar sir. And my dear friend Sneha writing good evening, Dr. Bhaskar. I don't understand why people are being so formal.
It's a webinar. It's a webinar on a national level.
That's okay.
So we move on to session 2.
Yeah.
Dr. Shabana, are you
Yeah,
there?
we are moving for the session 2, and for chairing this session, that is on the PCOS New Horizon, and the speaker is Dr. Priyanku Roy. I invite Dr. Supriya Jaiswal and Dr. Rekha Jha to kindly chair this session. Can I have the CV of the chairpersons? Dr. Supriya Jaiswal is MBBS DGU FIC OG FI CMCH, Vice President Patna Obstetric Gynae Society, Chairperson Adolescent Health Committee Foxy, Joint Secretary Sobi Bihar Jharkhand Chapter, Chief Consultant CM Hospital Patna, Executive Member Central ISOPAP, Executive Member SR Bihar Chapter, Executive Member IAG Patna Chapter, trained in colposcopy at Foxy Certified Center, awarded with MP John and Dr. J.V. Ellen Murthy Award for the best paper in obstetric, recipient of various awards and certificate, and held various posts of Joint Secretary, Clinical Secretary, Executive Committee Member, Treasurer, Secretary of Patna Obstetric Gynae Society, and presently Vice President. Organizing Secretary, Boxicon 2022, and Joint Secretary of Boxicon 2014. Her special interest is high risk pregnancy in preventive oncology. We welcome you, Madam Supriya, Madam, for chairing this session. Can I have the next CV of Dr. Rekha Jha? She is President Bhagalpur Obstetric and Gynecological Society, East Zone Coordinator of Public Awareness Committee Foxy, Organizing Chairperson 9 AOGSBJ, Scientific Chairperson IMA Bhagalpur, Past Secretary IMA Bhagalpur, Past Vice President IMA Bhagalpur, Past Secretary Bhagalpur Obstetric Gynecological Society. She is life member of Bhagalpur Menopausal Society, past RCH Coordinator, life member Menopause Society, life member Red Cross, work in various capacities with many NGOs and Rotary Lines, Jeevan Jagriti, Anti-Corruption Bureau. We welcome you, ma'am, Rekha ma'am, for chairing this session. So I request one of the chairperson to kindly introduce Dr. Priyanku for his talk on PCOS New Horizon.
Ma'am, Dr. Rekha Jha ma'am has not joined because she's not well. So we have Dr. Supriya ma'am.
Supriya ma'am is there?
Yes. Yeah, I'm there.
Ma'am, kindly introduce.
Supriya ma'am is equal to 3 chairpersons. And Supriya ma'am, I take this opportunity. Please give chance to Symbiosis Series. Whenever you feel like, we would like to coordinate and we would like to have a wonderful session only on adolescents. It will be so wonderful. Dr. Anita, today she talked on adolescents, but if we could have 4 hours devoted to adolescent topics, that will be just a big boon for the entire society and for Bhopal Obs Gynae Society, a great pleasure.
That's a very good initiative. Yeah.
Yeah, Dr. Priyankur. So a very good evening to all of you. And I'm very happy to be a part of this Symbiosis Series webinar 3. And I thank the Foxy Public Awareness Committee, the Bhopal OBGY Society and Bhopal Menopause Society, who have all three collaborated together to make this program such a wonderful, I can see the scientific, very nice. I thank Dr. Priyankur Roy, Dr. Monica Singh, Monica Omarwan, and all of you, the whole team members who make it such a wonderful event. So just to formally, he's a very close friend of ours. Dr. Priyankur Roy needs no introduction actually, because he is friend of all. He is very humble person. So just he is the chairperson at present Public Awareness Committee, Foxy, Vice President VETOG, FIGO, MCM SR India, Member Contraception Committee, FIGO, Member Scientific Program Committee, FIGO World Congress. Then he has been invited faculty in many international and national conferences, including FIGO, Foxy, AOFG, published so many articles, more than 75, authored so many chapters, that is more than 25 chapters, editorial board and peer reviewer of various journals like Jogi. So all of them, the prestigious ones. He's been awarded with gold medal for topping in MS University examination. Foxy
Thank you so much.
so you have many accolades and you're a very helpful person, very humble person. And over to you, Dr. Priyankur, for your deliberation.
Thank you so much, ma'am. So first of all, I would like to bring greetings from the Public Awareness Committee, Foxy, and I'm really thankful to the Bhopal Obstetrics and Gynecological Society and the Bhopal Menopause Society for allowing us to collaborate, and also, of course, to thank Dr. Randeep Singh sir and Dr. Monica Singh ma'am for allowing us to collaborate and putting in all the brain behind this Symbiosis series. We are lucky to be part of this third webinar, and I'm sure there are many more such webinars to follow in this series. First of all, I would like to wish Monica ma'am all the best for her future endeavors in Foxy and elsewhere as well. And with this, I think we will go ahead with this talk on PCOS. I think one of the most important talks, one of the important topics in today's day, I would say, because PCOS is now there in every house. And I think it is quite very important, quite very pertinent to talk about this topic in today's day. Before I start, I would once like to thank Rishikesh Pai sir, Madhuri Patel ma'am, and Alka Pandey ma'am from Foxy, and the Bhopal OBGYN Society President Anita ma'am, and the Secretary Sabana ma'am, and the Menopause Society President Shashi ma'am, and Shraddha Agarwal ma'am, who is the Secretary of the Society. I'd like to thank Shatabdi and Monica for being the backbone of the society and always being at the forefront in doing whatever activities we do. And Shabana ma'am and Purnima ma'am, who are the master of ceremonies for this program. Bhaskar sir, of course, it's a pleasure to listening to him as a chief guest, and guest of honors Arun sir, and as well as Manik Panse madam. Thank you so much. Monica ma'am, once again, thank you so much for giving me this opportunity. And I'm really thankful to Supriya ma'am for introducing me, for being a very close friend, associate for a very, very long time now. And thank you so much, ma'am, for being here. So we'll go ahead with this talk on PCOS Newer Horizon. I think I'll take 15 minutes of your time to talk about this, and I hope it will bring about some bit of additional points that will help you in your day-to-day practice. So we all know the regular things about PCOS, like the irregular cycles, the infertility bit of it, etc., etc. But we will talk about a couple of things which are not very common, but predisposes a person to PCOS, and that is something that we need to look at to try and prevent, so that the future generations as well as you yourself can be prevented to a certain extent from this dreaded thing of PCOS. I will use the word dreaded for PCOS. I use this word dreaded for endometriosis as well. These are not something which is magnanimous in considering towards the mortality of the patient, but they are magnanimous considering the morbidity of the patient. Especially in case of PCO, it is more towards the psychological, because infertility is a primary factor that happens here. Plus, in addition to that, there are factors like irregular cycles, there are factors like obesity, etc., which spoils the patient's moral, patient's boost, because of hair growth, because of obesity, because of irregular cycles, because of stigma, etc. And endometriosis, when we talk of, we know that, of course, infertility is one of the factors. In addition to that, pain, etc., is something that really becomes very, very morbid for a patient. So PCO, the impact of environmental factors such as nutrition and pollution and the mediating genetic and epigenetic pathway is seen to a big extent in women with PCOS today. There is a compelling evidence that many of the risk factors leading to most frequent chronic disease in adulthood originate from the earliest stages of life. And we all know the neonatal onset of adult disease concept, which is quite pertinent and valid in today's day. The environmental insults adversely affecting not only the exposed person, but also their descendants. Remember this point because it is very important, because it is not only affecting you, but it will affect the future generations as well. And that is why we need to be a little careful and make and try to be little less damages to our future generation. The economic consequences of a suboptimal start to life adds from a burden. So the variety of disease which are or which can originate right from the womb are like type 2 diabetes, insulin resistance, asthma, cardiovascular diseases, behavioral disorders, neurodegenerative diseases, reproductive disorders, some cancers. And to add on to the list, the second one which you can see, insulin resistance, we can add on PCO to that as well, because that is one of the factors which affects it. So what are the categories of environmental factors affecting hormones? Primary categories, if you look at physical, which includes light, temperature, radiation; chemicals, which include natural or synthetic chemicals; biological, virus and microorganisms, which I think in probably 5 years before or 5 years hence, we would have said, what probably can virus cause? But after COVID-19 pandemic, I think none of us are going to by any way deconsider any bit of virus or microorganisms causing any sort of a disease or any sort of a disaster to the world. We are again seeing the start of another respiratory ailment that is starting in China again. We just hope it is not something like COVID-19 again, which will again paralyze the world probably, but we are just hoping that things will settle down easily and we will not get into a COVID-19 pandemic scenario again because of this new virus, which God knows what it is. Behavioral factors, of course, stress, drug addiction, and other addictions as well, and socioeconomic factors like nutrition, habitat, occupation, etc. So is there a connection of fetal origin of adult disease in PCO? Now, this is a point that we need to ponder and look at. And there comes the most important word from this entire presentation. If there are 3 words that you need to remember, that is endocrine disrupting chemicals. In short, it is called EDC. So endocrine disrupting chemical is something which adversely affects, and that is the connection of the fetal origin of adult disease, especially in cases of PCO. So it can be synthetic as well as natural. EDC have the ability to mimic the effects of endogenous hormones and can make changes in the steroidal hormone levels. These characteristics will lead to the harmful effects on human hormones as well as fertility. So what do you feel are the causative factors linked with PCO? We have talked about this. Genetic factors, environmental toxins, as well as the socioeconomic status, which are factors which can be linked to PCO. The environmental factors which are important. Now look at this list. Everything in this list that you look at are connected to our daily life. Most of it we do daily or we try to avoid, but unfortunately we fall into it because I think one of the important factors over here when we talk about this is food. You see the last line when I come to it, we talk about fast food, we talk about uncooked animal derived food, etc. And I think somehow or the other, all of us like eating fast food, and that predisposes us to a long bit to this factor or to this disease called PCO. The other factors, as I've already told, endocrine disrupting chemicals, that is the EDC, dietary related weight gain, gut microbiota, lack of exercise and physical activity, socioeconomic status, and advanced glycation end products, that is AGE. Dietary intake together with tobacco represents an important source of exogenous AGE. So what we need to remember over here is that more or less every factor that we talk of can predispose us to one disease or the other in today's day. And why does that happen? We have been, or our ancestors have been eating for so long and no much of disease have been happening to them. And the factor they did not have and that we have is the adulteration of food products, chemicals in the food products, etc., that predisposes us to most of the diseases that are of the present and were not present to a great extent in the past. Now, what environmental toxins do you see most commonly linked to PCO? So we look at the 2 important things over here, and I will describe briefly the picture you see on the right side as well. So the 2 important factors that you see over here, number 1 is bisphenol A, and number 2 that you see is dioxin. Now, these two factors are primarily linked with PCO. If you look at bisphenol A, that is surrounding us in all sorts of ways. If you look at BPA, and if you, all the women who are present in this session, or to all your friends who are present, if you just take any of the makeup products which are not of any of the proper companies, by proper companies I mean, you will know it better, but by proper companies I mean, in today's day people advertise and talk about products which are BPA free products. BPA is bisphenol A, which to a great extent can predispose you to this disease called PCO. Second, you look at is dioxin. Dioxin is persistent environmental pollutant found specifically in manufacturing processes of herbicides as well as paper bleaching. And remember, dioxin is a product that is present in the synthetic sanitary pads as well. That is why it's important for us to try and avoid synthetic sanitary pads as much as possible and move on to the old generation cotton pads. I know it is difficult. I know it is not an easy advice to give. I know it makes sense, not too much of sense. But when you talk about the long-term effect, it's best to avoid the synthetic sanitary pads, because cotton pads or even tampons or even menstrual cups are things that, if used, can reduce the chance of dioxin toxicity or dioxin being spread in your body, which can predispose you to PCO in the future. Now, EDCs pose the greatest risk during prenatal development. Remember, when your baby is in utero, and if you are using products which contains bisphenol or dioxin, that is EDCs, it causes a major harmful effect to the baby as well. EDCs cross the placental barrier, and the fetal liver is not mature enough to detoxify it. It is hypothesized that prenatal exposure to EDC may contribute to PCO development subsequently. Now, how will you counsel patients accordingly in reducing exposure to endocrine products? One slide, the most important slide in the entire presentation, if you look at, is this one. I pointed out one slide in the previous slides, but this is the other one that I will talk of. And in this, the three headings that you see: avoid plastics as much as possible. Number 2, personal care products which are safe. And number 3, food and cooking things which are safe. When we say avoid plastics, there are things that we need to avoid. Number 1, of course, is no sippy cups or plastic baby bottles for children. Number 2, one of the things that we have started doing a lot, we buy sandwiches which are wrapped in plastic, heated in the microwave and given to us, thinking it is hygienic and it is better. Remember, any plastic thing which once heated, it releases compounds which are not good for your health. Number 3, one of the most common mistakes that we do in our day-to-day activities is we go out in the car in the morning, keep a water bottle thinking we'll sip something in the daytime, leave the car in the sun. Remember, sun-heated plastic bottles releases dioxin, and that is something that is not very good for your body and can predispose you to PCO. Number 4, refrain from using plastic containers. We were in a stage where we used to use Borosil containers to heat in microwaves, but I think because of the Borosil breaking, etc., we have shifted to the plastic containers, and we now go to the store to ask, is this plastic container microwave proof? I have done it myself, so I'm sure you guys would have also done it yourself. And when you find a plastic container which is microwave proof, if you use it, that can predispose you to EDCs and can lead to PCO, etc. complications. And number 5, we always think non-stick pans are the ones which are safe, less oil, etc., etc. But believe me, non-stick pans, the coating that is there contains EDCs, and that once we eat food from there can also predispose us and can cause PCO in future. Personal care products. I'm sure we have approximately 22 participants, which I'm sure are faculties, and we have a lot more delegates over here. And all the ladies, all the females, respected madams who are present over here today, we are not going to like me much after I say this, but I better say this because it's for the prevention of complications that might otherwise happen. That is personal care products. Read labels of sunscreen and makeup. Avoid parabens, 4-MBC, as well as benzophenols. So as I said, BPA free products is something that we need to take. Also, the bills that we get in most of the corporate houses like Big Bazaar, like Spencer, etc., they give you a bill in which in a shiny paper it's printed on with a black ink, which disappears if you keep it in your wallet for around 6 weeks to 2 months. This contains BPA, and even the ink of the receipt, if it's we are predisposed to for a long time, can cause EDCs, and that is something that is can predispose you to EDCs and can cause PCO in the future as well. So we need to be a little more careful about these things. Food and drinking, I will not highlight too much about this, because if I highlight too much about this, you will ask me what should I eat then, because I have to eat only air, probably, which is also not very safe in today's day. If you're talking about Delhi and Calcutta, even the air will cause respiratory ailments, GIT ailments, etc., because there are so many pollutants there. But the food and cooking, the list that is over here, contains everything, right from milk products, right from vegetables to meat to everything. And I do not know what to tell you to eat, but what I understand is if vegetables are organically grown, it is the best. If you eat meat which is not infused with any chemicals, that is what is good, and that can be eaten, and that is something that can be used. So I think this is something that we can talk about and that we can use for prevention of as much as EDCs as possible. And number 3 point is peel all non-organic fruits, vegetables if possible, because non-organic will have chemicals, and that best peeled for prevention of PCO-like complications. Now, is there any relationship between obesity and PCO? Never forget, your health is an investment and not an expense. I have talked about this previously also. I'm sure a couple of you would have heard about this before also, but I will still reiterate the same point for my friends who are for the people who have never heard me before. So it was in my OPD where I primarily practice fertility here in Siliguri, and I advise most of my patients for reducing weight before they come to me. So this one patient who came to me before 4 to 5 months now, she was 70 kgs when she came to me in the OPD. I told her, please come to me after 3 months. Please try and lose at least 1 kg of weight per month, which I usually give them a target of. So I expected that she'll come back after 3 months with a weight of 67 kgs. But unfortunately, she came back to me after 3 months with a weight of 74 kgs. So I looked at her and I said, I thought I told you to lose some weight, but instead you have gained weight. She kept quiet for 30 seconds, looked at me, and she said, doctor, from the last time I saw you, you also haven't lost any weight. So from then on, the prescription which contained weight loss in capitals and underlined has gone off. But I still verbally tell all my patients, lose weight, because that is something that will help you really. We can see this image over here. I mean, of course, we know which image over here is looking beautiful. Beauty is, of course, in the eye of the beholders, but your inner beauty is something that we need to look at. With obesity, there are a lot of complications in which you lose your self-esteem and you lose your confidence as well. So obesity leading to insulin resistance is one of the major root causes of PCO, leading to infertility. Obesity-associated PCOS results in type 2 diabetes, and obesity, which occurs in 30 to 75% of women with PCO, increases the magnitude of hormonal and metabolic dysfunction in this woman. Benefits of weight loss. Do I need to tell you this? I better skip this slide because all of us know the benefits of weight loss. I myself have been trying to lose weight but haven't been able to lose weight. I'm still trying, not very successfully yet, but I'm sure in some time I'll be able to tell you the benefits myself after losing weight, of course. Now, how do you counsel patients on diet and nutrition? Very, very important. And I think when I talk of diet of nutrition, I say one thing, there is no point of...
Mummy?
So
Dr. Purnima, please mute yourself. Dr.
Thank
Purnima,
you.
mute yourself.
Yeah, ma'am, she's muted. Thank you, ma'am. Yeah. So new diet and nutrition, I think it is important to talk of, but also the fact is that nutrition is definitely makes a diet chart and gives us. It's best to follow that, but sometimes the problem is most of the things that a nutritionist gives us is not something that we like eating. That is why what we do is we follow it for probably 15 days, and after that we are like, it's okay. Let me try and eat lesser of what I already eat. So what I tell my patients is the 4 important things that if we reduce, because I never tell my patient to stop anything, because if I tell them to stop something, they're going to stop coming to me rather than doing any stoppage that I've already told them. So what I tell them usually is to reduce. So the 4 important things is rice. Number 2 is oil. Number 3 is sugar. And me being from Bengal, I definitely talk of sweets because there are sweet shop probably after every alternate house here in Siliguri. So that is why I think sweets, sugar in tea, oil and rice. These are the things, if reduced, helps you reducing your weight loss. And never give a bigger target to your patient because it doesn't work out. For me, it's more or less, I tell them 500 grams per week. If you can lose 2 kgs a month, that is more than enough. And that itself is a target which is sometimes difficult to attain. Dietary supplements, yes, to certain extents, inositols, omega-3 fatty acids help, but all the extracts, tea extracts, coffee extracts, I don't know what, Chinese herbal extracts, what all are coming today, please do not prescribe those to your patients until and unless you have scientific evidences for the same. And based on that, if you have something, you can go ahead and prescribe it. Now, what are the diagnostic pathways you would take? Of course, we know that safety is gainful, but accident is painful. And that is why we need to diagnose things well. I will not go through this chart. Most of us have gone through this chart. This is there in most of the textbooks. So this is basically to rule out PCO from idiopathic hyperandrogenism, idiopathic hirsutism, as well as NCCAH. That is non-classical congenital adrenal hyperplasia. So the factors primarily, when we talk of history and examination, I just like to reiterate what my father, who's also a gynecologist, says, that in today's day, probably the gynecologists consider the right hand to be a laparoscope probe and the left hand to be an ultrasound. But we forget the two important skills that we have. Number one is a good history taking skill, and number two is examination skill. Because if you examine our patients well, most of the diagnosis is written on the face and written on the paper rather than getting all the investigations done. But considering in today's day, definitely investigation is something that we need to do to rule out or to prevent medical legal complications. But please do examine and take a proper history before going on to anything else. So there are a few non-dietary interventions that we can do in PCO, especially exercise intervention, dietary interventions, as well as behavioral strategies, which are important. Daily 10,000 steps is ideal, but since I do not do 10,000 steps, it's wrong on my part to advise to my patient. So what I normally say is 2,500 to 5,000 steps. If you can do, that will help you in gaining what you need to gain in probably a week's time, that is 500 grams only. Dietary interventions I've already mentioned. Behavioral strategies is probably things like small amount repeated eatings is better than eating once, not eating the whole day and eating once a large quantity, which I used to do in between, and I gained 2 to 3 kgs instead of losing any. So I think that is something that we could do, and that will help us. Pharmacological interventions, menstrual irregularities, we all know it could be any bit of low dose COCs. If the patient is non-tolerant, metformin, myo-inositol, etc. And there are OCPs in today's day which has got fourth generation, etc., which are quite very safe and quite easily given in case of PCO. The pharmacological interventions for acne, hirsutism, and alopecia, I think it's mainly COCs considering drospirenone or desogestrel, and now there are even dydrogesterone containing OCPs that are coming in, which we probably will have to look in later. Hair removal, topical ointments or some lasers, etc., and look for other signs of CAH. But remember, diagnose the patient what exactly she has, and based on that, do the treatment that is required. This is a newer concept. The last two slides that I have that I wanted to talk of. This is something that you can talk to a patient about. That is, all diseases begin in the gut, was once said by Hippocrates. And for cases of PCO, also it is true, because now it is said that dysbiosis is one of the factors that can cause PCO. There is evidence for microbiological dysbiosis and a leaky gut in case of PCO. So basically, in case of dysbiosis, we have a high chance of PCO. Thus, they say probiotic to a certain extent help in prevention of PCO if in case the patient requires long-term antibiotics, etc. Thus, irritable bowel syndrome and chronic fatigue syndrome linked to increased gut permeability and metabolic endotoxemia have both been shown to be significantly more common in cases of PCO. And lastly, I would like to talk a little bit about laparoscopic ovarian drilling. And everything in today's medical science has got some role. We need to remember that. Nothing we can say does not have a role. All fingers are not the same. You just need to adjust your patient, or you need to do it best what you feel is best for your patient. So even ovarian drilling has some bit of role, but what I would like to say is drill it like the picture on the right and not the picture on the left. That is, you keep drilling till it becomes charred and looks like a golf ball rather than an ovary. So you have to drill it. The rule of 4 is what we need to follow. 4 drills, 4 joules for 4 seconds each, 40 joules for 4 seconds each. And that is what is the rule of 4 that we should use in case of PCO. Now, one slide of principle of consent. So I talk like a little bit about the principles of consent, depending on what option you give to treat the patient in PCO. And for that extent, we need to listen to the patient have complaints, discuss the options, share all the options, respect the decision of the patient, and make this medico-legally completely sound for yourself. And when I tell medico-legally sound for yourself, for everything that you do for your patient, you need to take a consent, which is very, very important. I finished my fellowship in 2017 from Dr. Vineet Mishra sir in Ahmedabad. I came back to Siliguri, where we ran a small nursing home, me and my father. So the consent at that point of time in my hospital read, the in front paper was the admission sheet, and the sheet behind was the consent form, which read, I, Mrs. Dash, wife of Mr. Dash, hereby give the hospital, give consent to the hospital to do whatever you want to do with me. Now, that is not a consent that we should take, right? We have to take a consent regarding whatever procedure we do, whatever treatment we do in a proper format. Foxy has got 80 consent forms which are there in the Foxy website. You can download it and you can use it. These consent forms have been made by 5 medical legal experts with the judge of the Mumbai High Court, who have collaborated together and made the consent forms. Take a printout, fill up the details of the wife and the husband. And remember, for a consent form to be complete, you need to take 5 signatures. Number 1, signature of the patient. Number 2, signature of the husband. Number 3, a witness from the patient side. Number 4, your signature. And number 5, a signature from your side. So from a witness from your side. So totally 5 signatures are required for a consent form to be full. And I end by saying, eat less, walk more, very pertinent for PCO, none of which I do, of course, and thankfully I can't have PCO. Do necessary, talk more. I'm sure all of us do this. Work enough, which is very, very important, and all of us do it. But unfortunately, we falter on the writing more part because we do not document things. And in the court of law, if you do not document, it's considered not to be done. So thus, please talk, counsel, please document, and please document everything for your safety. Thank you so much for this opportunity. And I end by saying, not that we know better about the risk of hormones disrupting chemicals. We must have the courage to be cautious, for the stakes are very high. We owe that much and more to our children, because EDCs can cause problems to your children as well. Thank you once again for the opportunity, and I hope it was of some value to your daily clinical practice.
It was wonderful. Thank you for your wonderful deliberation, Dr. Priyankur, and congratulations. Actually, being the Public Awareness Committee chairperson, you have really made people aware by your talk about the environmental toxins, about so many lifestyle management, what to do, what not to do, do's and don'ts, everything you have explained so well, and the new horizons, what we see. And really, the adolescents are a difficult group to tackle because they don't come up to you, they don't open up, and they try to be more close to their peers, and peer pressure is too much for them. So difficult to handle this lot, and PCOS is the most common thing they are facing these days. So very well said, and you summed up everything beautifully. Thank you very much.
Thank you so much, ma'am.
It was very nice.
So, Dr. Priyankur, it was
Wonderful.
wonderful. Excellent talk you gave.
Thank you so much, ma'am.
And the cosmetic part.
Thank you, chairpersons.
I wanted to just comment on the cosmetic part. Sometimes these college girls, even my daughter is in college, though she is doing internship, so she doesn't use too much of makeup. But when they party and all, they will just put everything. So these girls in hostel, they go for some economical brands. They feel that one lipstick 1,500 rupees. It is better we buy everything of 1,500. So that's where they land into the trap of biphenyls and so many things.
Yeah.
So it's always my endeavor. I give her extra pocket money that you buy one brand which is good enough, and don't go into that trap. That has to be educated to our children. If they are fond of, either don't use makeup, or if you use makeup, you use good brands. That's very pertinent. Second thing is this microwave thing. The microwave thing has taken, like, even the maids are using, just putting everything in dishes and warming. They don't want to use the gas stove and everything, they find microwave very easy. Usi mein garam karke, usi mein they put it on the dining table. So this change has to come. You have to literally, there was a time when I threw all the plastic into the, dustbins. I said, then they brought more, so you get gifted, and these gifts are so horrible, you get gifts with lots of plastics. What to do? And sometimes even you don't want to throw new things. So it's a trap. We have to come out of the trap.
And I think the bottles, plastic bottles in the cars as well, try avoiding that as much as possible, because that also heat is not nice. And on the lighter note, I think let's just say that since Monica ma'am says if she feels that it will be good for you, she gives you extra pocket money. So if we want something good for ourselves, we can always go to her. I think that's the take home from today's this webinar. Thank you so much, ma'am.
Yes.
So I think beautiful and practical point explained beautifully. So we move forward for the third session, and I hand over it to Dr. Purnima for starting third session and panel discussion later on.
Thank you so much, ma'am. So for our third session, yes. So the third session, the topic is PCOS and infertility, double trouble. Our speaker is Dr. Monica Singh, ma'am, and our chairpersons are Dr. Nivedita Datta, ma'am, and Dr. Ranita Roy. Next slide, please. So, Dr. Nivedita Datta, ma'am, she is a consultant in Gynae and Obstetrics, President, Bokaro Obstetrics and Gynecology Society. Ma'am is East Zone Coordinator, Safe Motherhood Committee, and also Manita Coordinator, Jharkhand. Ma'am is Palliative Care Specialist and also Secretary of an NGO, Koshish Rural Based Central Providing Holistic Care. We welcome you, ma'am, on this platform. Thank you for joining us today. Yeah, our next chairperson is Dr. Anita Roy Chaudhary. She is Associate Professor, College of Medicine and JNM Hospital, Kalyani, Nadia, President, Kalyani Ops and Gynae Society. She is having interest in high-risk pregnancy and urogynecology. Dr. Anita, ma'am, thank you for joining us today. So, yes, I would like to hand over this session to our chairperson for introduction of our speaker.
Thank you. Thank you, Purnima. And it's a pleasure to be with you all today. It's an honor to be invited to attend this session and listen to such wonderful talks. Priyankur, you're delightful as ever. It's an honor to invite the next speaker, the backbone of Symbiosis and an expert in reproductive medicine, Dr. Monica Singh. She is the professor of Ellen Medical College, a consultant in reproductive medicine, Bhopal Fertility and Endoscopy Center. The vice president of Bhopal Society holds an important post in ISAR and has a credit of many conferences, publications, and awards in her field. In her field, she's the apt person today to throw light on the burning topic of PCOS and infertility, double trouble.
Thank you so much. Thank you, Dr. Nivedita, for the kind introduction. And it's really beautiful to be amongst all of you today. And we've listened to, brilliant talks by Dr. Anita, where she dealt with adolescents. And we are lucky to have the adolescent committee chair with us, Dr. Supriya. Means sometimes God just puts two and two together. And Priyankur is there. I thought Priyankur, what's he going to talk about? But he took us through the journey, He took us through the mistakes we are making. Right from the milk we are consuming, the milk packets which come to us. So, a few years back, I also made the change. I changed from the packeted milk to the doodwala. So the doodwala, he comes in, he gets that traditional, aluminium cans, and then we take it into a utensil, then we boil it. The small changes we have to make, just to keep, because you have lived your life. Probably I just have a few decades left. You people have one more decade left. Priyankur has 3 more decades, 4 more decades. Purnima has 5 more decades left. But at the end of the day, what are we going to leave our children? We are going to leave our children a world with less water, glaciers gone, animals gone, only air conditioners working, temperatures touching 50 degrees, a lot of metabolic disorders they'll be combating, a lot of cancers they'll be facing. So many COVIDs will come and go. So I don't know. So whenever I misuse water in any way or try to give my car a wash once a week, it's my son who tells me, Mama, you're not giving the car a wash. You just go with that bucket and mug thing and tell the driver to wash it that way. So he is very particular. He's in AIMS. He's very conscious of the surroundings, and he wants to have a world which is he's able to live in. So coming to my talk, I'd like to share my screen, because after all these social talks, we come to a fertility talk. Yeah. Can you see my screen?
Yes, ma'am.
Okay. So this talk is about a double trouble because PCO it is a big trouble to all of us. And now we have infertility along with it, which makes it a double trouble. I have taken my slides or recommendations from the 2023 guidelines. Before we begin, this is actually not a serious disorder, though the slide says so, but definitely this is a disorder where genetic, hormonal, metabolic, and reproductive issues affect women. And though 10 to 15% is the prevalence in the population of women, as many as 50% of these women go undiagnosed. 50% of those with PCO will develop type 2 diabetes before they turn 40. There is a whole lot of burden on the healthcare system of any particular country, and India is going to be one. And these women also are at increased risk of developing endometrial cancer as they age. Polycystic ovarian syndrome is the most common endocrine and metabolic disease in women of reproductive age, but not all women with PCOS experience infertility. We know ovulatory disorders make up about 40 to 45% of all causes of female infertility. And it is interesting to note that out of all these ovulatory disorders, 85% are PCOS. So this is the traditional diagram we saw in textbooks. TVS, the gold standard, wherein you get a beautiful picture. The ovaries are literally falling on the probe and giving you that multifollicular, polyfollicular necklace sign, black pearl sign, whatever you call it. But nowadays, the realm of PCOS is much beyond just doing a good TVS. You have to know if you are the consultant, reproductive medicine, or you are consultant, OBGY, practicing in any level, any city, you should know what is biochemical hyperandrogenism. You should know what is clinical hyperandrogenism. You should know how to define oligoanovulation and polycystic ovarian morphology, that is PCOM. So this was interesting to me. So I thought I'll share with you because treatment everybody knows, but we should know how to approach a patient. For detecting biochemical hyperandrogenism in a patient who is not overtly hirsute, for hirsutism, you have to use the modified Ferryman-Gallwey score. Please go through this score, and it has to be more than 4 or more than 8 to call that woman hirsute. Now remember, there is similar prevalence of hirsutism across all ethnicities, but it is the severity of hirsutism which is different in different ethnic groups. Now, if this woman doesn't have hirsutism, we have to test for her biochemistry. Here, what we do is test for total testosterone, free testosterone. We can go for free androgen index, bioavailable testosterone. Sometimes it's not recommended, but in the books, you can also go through DHEAS and androstenedione. And remember, the lab assays should be standardized. Don't go for just any lab where they do the tests. I've already talked about Ferryman-Gallwey score. Oligoanovulation, we know, where the woman's cycle is more than 35 days apart or she has less than 8 menstrual cycles in any year. So if you do not have these features, you can consider doing a serum progesterone level or luteinizing hormone assessment. Polycystic ovarian morphology, all of us are very deft with the TVS probe nowadays. The criteria has changed a little bit. Now it is follicular number per ovary, more than 20 follicles per ovary in either ovary, and more than 10 ml of ovarian volume, which used to be 6 ml earlier, now it is 10 ml. And of course, you should not assess by transabdominal probe, but with a TVS probe with a frequency of minimum 8 megahertz. Now, PCOS classification has evolved over the years. There was a time in 1990 when NIH talked about hyperandrogenism and oligoovulation, and both of these criteria were required to classify a woman as PCOS. ASRM and ESHRE came up with the Rotterdam criteria, wherein 2 out of 3 criteria were required out of hyperandrogenism, ovulatory dysfunction, and polycystic ovarian morphology. So we were very comfortable with this classification. But then, to create some trouble. Everybody wants to create some trouble. They don't like a smooth life. We had this androgen excess society. In 2006, they said, no, nothing is required. That patient has to be hyperandrogenic. So they made hyperandrogenism a must to diagnose PCOS with either PCOM or ovulatory dysfunction. So both these were required. So every patient they diagnosed as PCO had to have hyperandrogenism. Next, we came to 2012, where again ESHRE, ASRM got together, racked their brains, and they came out again with the Rotterdam criteria. They again started following Rotterdam criteria, but they gave us the phenotypes A, B, C, D. Today, I'm going to talk about very scientific evidence. These are the recommendations from the 2023 International Evidence-Based Guidelines for Assessment and Management of Polycystic Ovary Syndrome. And this has been published as recently as August 2023 in the Journal of Clinical Endocrinology and Metabolism, very relevant to today's gynecologist. Now, this might be boring to some of you, but I think it's very important we understand that what did they want? After doing such a lot of PCO last 3 decades, what did this consensus group want to achieve? They wanted that what is the recommended assessment and management of women with PCOS based on the best available evidence, clinical expertise, and consumer preference. And they came out with 254 recommendations and practice points. Their aim was to promote consistent evidence-based care and improve the experience and health outcomes in PCOS. Earlier, I talked about 2018 International PCOS guidelines. These were good, but they were consensus-based. Here in 2023, I'll just use my pointer. Yeah. In 2023, this guideline, the panel included pediatrics, endocrinology, gynecology, primary care, reproductive endocrinology, obstetrics, psychiatry, psychology, dietetics, exercise physiology, obesity care, public health, experts, consumers, project managers, evidence statisticians, and translation experts. So these guidelines were developed and approved via consensus across 5 guideline panels, peer-reviewed across several continents, and ultimately approved and given to us. So these can be categorized into 3 categories. Now, whenever you read recommendations, you sometimes, doubt the recommendations, whether to follow or not. So remember, the best guidelines are the evidence-based recommendations. This evidence is sufficient to inform a recommendation made by the group. Means you can follow it blindly. Second is consensus recommendations. Here, the evidence may not be adequate, but a consensus has been reached by the Guidelines Development Group, or the GDG, from evidence collected in the general population. And third are practice points, where no evidence is sought, and the group has just taken important issues from discussions, from consensus, and given it to us. And again, you should know the quality of the evidence, the category. So you must have seen these stars in front of the evidences. So when you see these 4 stars, you should be very confident that if you use that measure or that treatment strategy, the effect will lie very close to that of the estimate of the effect. So whatever the guidelines providers gave us, that our effect will be close to that. Wherever there are 3 stars, this is moderate confidence in the effect estimate. Where there are 2 stars, there is very limited confidence in the effect estimate. And 1 star is very little confidence, where you are better off not following that strategy also. So this group gave us a diagnostic algorithm for PCOS, which was divided into 3 groups, and it's very simple to follow. The step 1 for diagnosis is you take a woman and see whether she has got irregular cycles plus clinical hyperandrogenism, means hirsutism. If both of these are present, you diagnose PCOS. Now, if this woman doesn't have clinical hyperandrogenism, Then you test for biochemical hyperandrogenism. I've already told you how, and you come to a diagnosis. Now, step 3, if this woman only has irregular cycles or hyperandrogenism, not both of them, then you have to turn to USG. But if she is an adolescent patient, then ultrasound, as told by Dr. Anita Srivastav, is not indicated. Wait, you consider that adolescent at risk of PCOS, give some time, few years to her, and reassess later. But if she is an adult, you request ultrasound for PCOM, and if positive, you diagnose her as PCOS. So my talk would be covering fertility affected, how it is affected in PCOS, investigations, and of course, evidence-based management. A huge part of fertility management is the lifestyle modification. I don't have to talk about it. The goals for weight loss. Yesterday, Dr. Lakshmi Srikhande ma'am was talking about this in an ICOG webinar. So I found this very nice. The goal setting for weight loss should be smart. It should be specific for that patient, whether she'll be able to do it. It should be measurable. She should be knowing how to assess her outcome versus her efforts, achievable. You can't expect a 80 kg woman to start running 3 kilometers. It should be realistic and it should be time bound and timely. So you have several measures. The goal setting, as you can see, they could include bouts of exercise, they could include progressively increasing physical activity. The recommendations for mild weight loss are given in the guidelines, moderate weight loss, and definitely every guideline, every recommendation is based on the background of daily exercise minimum 4 to 6 days a week. You cannot skip. You cannot say that I'll not exercise for 2 weeks and then I'll catch up on the third week. You have to take it and make it a part of your routine. Role of anti-obesity, because I'm talking about lifestyle, I'll also talk about things like orlistat and the drugs which have come. These pharmacological anti-obesity agents should be considered only an experimental therapy for the purpose of improving fertility, because the risk to benefit ratio here, whenever we talk about a recommendation, we have to weigh the risk against the benefit. In fact, I was going to just, when Priyankur was talking about his patient, wherein he used to write on the paper weight loss and underline, I used to do the same thing. But now the recommendations are you cannot even take the weight of a patient without her consent, because that will be demeaning to her confidence, that will bring her self-esteem down, that will humiliate her in an OPD. So you cannot take weight of a patient who appears to be overweight or obese as far as recommendations are concerned, unless you have the consent to do so. So is there any role of bariatric surgery? This is again an experimental therapy in women with PCOS, and the risk benefit ratios currently are too uncertain to advocate this. But if this woman undergoes bariatric surgery, she should avoid pregnancy during the periods of rapid weight loss, and for at least 12 months after bariatric surgery, she should use appropriate contraception. If pregnancy occurs, there should be awareness and preventive management of the pre and post-operative nutritional deficiencies, which are very common, ideally in a multidisciplinary setting. And you have to monitor the fetal growth very, very carefully. So this is how the lifestyle management goes. Don't stress the patient for reaching that ideal weight. Just now we were in Femtech, Priyankur, myself, so many of our friends, and we saw Dinah Penty and we thought we are the most useless creatures in the world. You know, we eat so much and everything. But remember, PCOS patient, she has to be just told gently that you have to reduce only 5% of the body weight and that you are good. So just encourage her. In fertility management in PCOS, you have to assess the patient for factors like blood glucose, weight, blood pressure, and all these things, smoking, alcohol, diet, exercise, sleep health, mental health, psychosexual health, because these women are basically, depressed. So you have to, I'm reading only the 4-star recommendations. These women with PCO should be counseled on the adverse effect of excess weight on clinical pregnancy, miscarriage, live birth rate, following infertility treatment. And with the routine preconception care in women with PCOS planning pregnancy, weight, blood pressure, smoking, alcohol, diet, nutritional status, folate supplementation has to be done at a higher dose if the woman is obese. She has to be counseled about exercise, sleep, mental, emotional, sexual health, and this all should be optimized to improve the reproductive and pregnancy outcome and overall health. The principles of ovulation induction, all of us know the drugs, but pregnancy, because these women sometimes come to us with amenorrhea, and sometimes, so many times, I've just inserted into the probe into the body of a patient who's complained of amenorrhea, maybe 45 days or 55 days, and she said she's never been pregnant, she's obese, she is, infertile for maybe 15 years, and I see a sac. So, pregnancy should be excluded prior to ovulation induction, and unsuccessful and prolonged use of ovulation induction agents should be avoided because it leads to a poor success rate. Out of the general recommendations, only prenatal vitamin supplementation should be commenced with ovulation induction therapy aligned to routine preconceptional care. This is important. And another thing is that when you use ovulation induction agents, we take it so lightly, letrozole, metformin, clomiphene citrate. But remember, these drugs are used off-label in many countries. So you should have a monitoring of the patients for adverse effects of these drugs. And remember to monitor the infant also after it's born for congenital anomalies. And whenever you find such a baby, you should report your finding or whatever has happened. Coming to CC, letrozole, metformin, I don't want to speak much. You all know that letrozole should be the first line pharmacological treatment for ovulation induction in the infertile anovulatory woman with PCOS who has no other infertility factors. You can also use clomiphene citrate with metformin. Metformin can also be used alone, but remember, when you use metformin alone, it can improve clinical pregnancy rate, but you have to inform the woman that there are more effective ovulation agents available than metformin. With CC, remember, you might get multiple gestation. You have to warn the woman, give her the choice. Gonadotropins, once you use these gonadotropins, are a double-edged sword. We've heard from so many people. I'll read out only the important recommendations. Gonadotropins can be considered even as first-line therapy in PCOS, where the woman is ready, the doctor is ready to monitor, explain everything, because they definitely improve ovulation, clinical pregnancy rate, and live birth rate. Now, they can also be used in women who are having clomiphene citrate resistance or failure and no other infertility factors. You can also use gonadotropins along with laparoscopic ovarian surgery because these come under actually second line therapy. And where gonadotropins are prescribed, it is very, very important that the cost of the intervention should be explained to the woman because she is given a budget of, with letrozole, she's given a budget of IUI of 5 to 10K. And with gonadotropins, it can go up to 20K, 18K. So she should be told expertise is required for the use of gonadotropins. A degree of intensive ultrasound monitoring is called for. You should always go for low dose step up gonadotropin protocol to optimize the chance of 1 or 2 follicles forming, and implication of potential multiple pregnancy should be explained. And I also explain the patient the need for sometimes converting the patient into an IVF cycle if need be. When to add metformin in patients who have clomiphene citrate resistance with a high BMI, because metformin addition is a wise step. It's a cheap drug. It has got minimum side effects. Some GI side effects are there which can be overcome, and it does improve ovulation and pregnancy rate. How to do the increments we know very gradually. One thing I wanted to point out was that prolonged use of metformin may cause low vitamin B12 levels, which have to be supplemented in such patients. Now, coming to tubal patency in PCOS. This is again a very strong recommendation. That is, if a woman is infertile with PCOS diagnosed with normal semen analysis, the tubal patency test cannot be done before explaining the patient the risk, benefit, and cost involved on individual one-to-one basis. It cannot be a blanket thing. And tubal patency test should be considered prior to ovulation induction in those women where there is a suspected tubal infertility. Psychosexual function has to be counseled to the patient. A score is there. Nowadays, the Foxy Sexual Committee is doing such a wonderful job. If there's sexual dysfunction, that woman has got a disturbed sex life and relationship, a scoring can be done, treatment can be done. Inositol in any form should be considered an experimental therapy. PCO drilling, doctor, I have used the same image as Dr. Priyankur. This is the right way to do it, where you use minimal drills. That's the wrong way to do it. And of course, this technique is there to stay. It depends upon the surgeons or the practitioner's choice, the patient's indication, and definitely it has a value in hyperandrogenism cases. Again, about PCO drilling, gonadotropins we've already talked about. These form the second line therapy. And when can gonadotropins be the first line therapy? Where they are available, where you can afford them or the patient can afford them, where there is presence of good ultrasound monitoring you can do yourself, and you have counseled on cost and the potential risk of multiple gestation. When not to trigger, remember in IVF patients or PCOS, your choice of trigger is agonist trigger. Your choice is to freeze the embryos and transfer in a segmental IVF form. So you choose not to give a trigger in IUI cycle when there are more than 3, or it may be 2 mature follicles, or it may be 3 mature follicles. You have to tell the patient about the risk of OHSS. So the protocol of choice becomes antagonist. For final maturation, GnRH agonist. Freeze all strategy. You can freeze the blast. You can plan the embryo transfer in the next cycle. And of course, monitor for OHSS. So this is the summary. I've already told you, you have to monitor this pregnancy very carefully and look for sequelae. We have to stop using inappropriate LH as a diagnosis. We have to stop doing LH-FSH ratio, which we were doing 10, 12 years back. We have to stop monitoring fasting insulin and PP insulin. We have to stop using steroids because they can, in fact, induce insulin resistance. So this is just a short summary of the assessment and treatment of infertility. First line, non-pharmacological management for infertility, lifestyle intervention. First line pharmacological management for infertility is letrozole, first line, CC plus metformin alone, and gonadotropins can also be used first line. Second line pharmacological / surgical management is with gonadotropins plus along with and or laparoscopic ovarian surgery. And third line management could be other appropriate interventions, including IVF. And nowadays we are talking about IVM again. So this is the central blue pathway which has been given by these criteria. You can go through it. That was a simplified form. This is the complete table which gives you the management. So these are my carry home messages. I've already spoken, so I'll not waste time. But nowadays, IVM has again come as a third line therapy where trigger is not given. The oocyte is taken out, the ICSI is done, and the embryos are frozen. And of course, for reasons of preventing multiple gestation and complication, a single embryo transfer should be preferred. The next part of my talk is PCOS phenotypes, which I think I'll skip because it'll take another 15 minutes and we have to do a panel. Thank you all for a very patient hearing, and I end my talk here.
Thank you so much, ma'am. Every time, ma'am, I listen to your talk, like I learn so many new things. So thank you so much for this wonderful talk. And Nivedita ma'am, our chairperson.
Yeah, I think it was an excellent talk and you covered it beautifully. You went about it so methodically, speaking about the protocols with which infertility management should be done in polycystic ovarian syndrome after giving the basic format of how to diagnose and investigate. Very well covered. I think it's going to be a great benefit to everybody. We would also be very happy if we could take on some questions in the series because I myself has a few questions. So It would be wonderful if you could give some time for discussion later and take on
But
some questions.
I would have loved to talk about the phenotypes. I mean, phenotypes, I was just
Absolutely.
reading
Actually, it's
phenotypes.
very important. It's very important to know the lean PCOs and the obese PCOs. It's very important to have the phenotypes because we get a lot of women out here. I'm in from Bokaro, Jharkhand, and Jharkhand, as you know, is a tribal state. You'd be surprised that PCO is pretty rampant out here, and we get a lot of lean PCOs, which are pretty resistant to most of the medications, and metformin does not work. So we have to move a lot into ionisitol. So I would love to hear your talk on phenotypes if you had the time.
Dr. Nivedita, I think we'll do it some other time because we are already 6:15.
I know, yeah.
The phenotype, you can see my slides. There are about 20, 30 slides of phenotype only, and it will require a separate talk, a very precise talk, a very methodical talk. And I'm waiting for more literature. In fact, I'm going to prepare a paper for ESHRE, which will be on PCO phenotypes very soon. So probably I'll be sharing my, data with you very soon.
I would love it.
Yes, yes, yes. So
this is something which is very important. Everybody speaks of the obese PCO, whereas lean PCOs are very common now.
Okay, yeah. So I have stopped share, and Dr. Purnima, you can proceed with the panel now.
Yes, ma'am. Thank you so much, ma'am.
Neha madam is there since the start of webinar. Thank you so much, ma'am. Ma'am is a very, very esteemed senior. She is like as important to us as our chief guest and guest of honor. And her cooperation means a lot to us. And we wish madam all the best in all the great path she's, following and wanting to reach to.
Thank you, my dear. Thank you for making me a part of this program.
Purnima, please proceed.
Hello. Am I audible, ma'am?
Yes.
Yes. My connection, yes. Okay. So for our panel discussion, the topic is PCOS across all ages, case-based approach. And our expert is Dr. Sonia Malik, ma'am. Ma'am is Director and HOD, Nova Southern Fertility and IVF Center, New Delhi, and recently partnered with IVF chain Nova IVF Fertility. She has been recently appointed as Chief Clinical Mentor, Nova IVF Group. Ma'am has been President, Indian Menopause Society, Indian Representative to International Menopause Society, Asia Pacific Representative to World School of Menopause, Vice President, South Delhi IMA, Senior Vice President, Indian Fertility Society, President IFS, Chairperson Infertility Committee FOXY, Member ART Cell FOXY, Chair Advocacy Committee IFS. Ma'am has been awarded with so many awards: IMA Kanak Goyal Award 07, IMA SDB Meritorious Service Award, IMA Lifetime Achievement Award, Delhi Government Best Doctor PNDT Cell, Lifetime Achievement Award, Haryana Obs and Gynae Society 2019. And she is editor for IMS Guidelines for Management of Menopause and has published the first IFS Indian Guideline for Management of PCOS in India, and has been invited as speaker at various national and international conferences. And also ma'am has been part of the various clinical trials. We are honored to welcome you, ma'am, on this stage in this webinar. Thank you so much, ma'am. Our next and the moderators of our panel discussion are Dr. Sneha Bhuya, ma'am, and Dr. Basab Mukherjee, sir. Slide, please. Dr. Sneha, ma'am, is an alumni of BJMC Session General Hospital, Pune. She's Managing Director, Sukh Karta Hospital, Maternity, Surgical, Nursing Home and Laparoscopy and Infertility Center, having 29 years of experience in the field. Ma'am has received many awards: National Individual Award, FOXY Anandita Bai Joshi Award, FOXY President Appreciation Award, FOXY President Appreciation Award for exemplary work in cancer, International MS Signature Award, Lokmat Healthcare Award, Champion of FOXY, National Expert, UNICEF and Lead Accessor. Ma'am has been Chairperson Breast Committee FOXY 19 to 21, Governing Council Member ICOG 21 to 22, Chairperson Medical Disorders Committee AMOX 22 to 24, Founder President Vidarbh ISOPAV 17 to 19, President BioGS 7 to 8, Founder Clinical Secretary Yorks 2003, Executive Committee Member Amox 2022. Ma'am has various publications in various journals and organizing chairperson of various conferences as well.
Thank you.
Research as well. Thank you so much, ma'am. Our next moderator is Dr. Basab Mukherjee. Sir is director at Ankuran Fertility and Fetal Medicine Center and has been organizing secretary in FORCE, Yuva Foxy Endogyne BoxCon. Sir has been Vice President Foxy, PIGO Regional Coordinator, Safe Abortion, Secretary IRC India East, President-elect Bengal Obs and Gynae Society, Vice President Kolkata Menopause Society, Secretary IAGE Bengal Chapter, and has received various awards, Yuva Foxy Orator, AOFOG Young Gynec Award, DC Datta Best Publication, Appreciation Award, Secretary Box 4 Foxy National Awards, TRG Member, Family Planning, and has been Clinical Examiner for MRCOG Part 3 as well. Thank you so much for joining us. Thank you. And our panelists are Dr. Sneha ma'am, should I introduce the panelists?
Yes, please go ahead.
Yes, in short, that will be better.
Okay, thank you, ma'am. Dr. Anju Ganodia, ma'am is Director and Consultant Ashirwad IVF and Fertility Center, Zonpur, alumni of BRD Medical College, Gorakhpur, has received various awards and is member of various organizations and having his area interest in infertility, gynae-endoscopy, and preventive oncology. Dr. Anju, thank you for joining us today. Our next panelist is Dr. Arun Kumar Singh, sir. Sir has been trained in IVF and reproductive medicine, is director at Pratiksha Fertility and IVF Clinic, Balasore, visiting consultant Jyoti Missionary Hospital, ex-assistant professor Asra Medical College, Iluru, joint secretary Iluru Obs Gynae Society, secretary North Odisha Obs Gynae Society, secretary Isopath Chapter Balasore, Odisha, and is member of various organizations. Dr. Arun sir, thank you for joining us today.
Thank you.
Next panelist is Dr. Joy Sankar Saha. Sir is senior consultant at Railway Hospital Chitranjan and HLG Memorial Hospital Asansol, ex-HOD at RK Mission Hospital Vrindavan UP, ex-consultant at SAIL Hospital, IP Secretary of Asanal Ops and Gynae Society, VP of IMA Asansol, recipient of Bharat Ratna Mother Teresa Gold Medal Award and Bengal Excellence Award. Thank you for joining us today, sir. Our next panelist is, next slide, please. Dr. Julie Chacharia, ma'am. Ma'am is senior consultant IVF and clinical head at Seeds of Innocence IVF Center, Guwahati. Previously worked as IVF consultant at Pratiksha Hospital, Guwahati. Ma'am is an alumni of JJ Medical College, Devangere, Karnataka, and has been trained in minimal access surgery from World Laparoscopy Hospital and fellowship in reproductive medicine from DY Patil, and has presented various papers. Thank you for joining us today, ma'am. Our next panelist is Dr. Poonam Mishra. Ma'am is Director of Manas Hospital and Manas Gynae Cosmetology and Laser Center, Lucknow, Secretary of Manas Seva Sansthan, President of Indian School of Aesthetic Gynecology, Chairperson Cosmetic Gynecology, IASRM SIG, Member of Sexual Medicine Committee, Foxy India, and has been trained in Aesthetic Medicine, Cosmetic Gynec, and Stem Cells and Regenerative Medicine, organized and participated as faculty in various conferences. Thank you, ma'am, for joining us today. And next panelist is Dr. Ranjana Jha. She's consultant gynecology, Katihar Seva Sadan, formerly associate professor, MJ Medical College, founder secretary, Katihar Ops and Gynae Society, presently vice president, Katihar Ops and Gynae Society, former secretary, Indian Red Cross, Katihar, presently vice president, Indian Red Cross, Katihar, and has received various awards as well. Thank you, ma'am, for joining us today. Our next panelist is Dr. Sakshi Singh. Ma'am is FNB in reproductive medicine and has been trained in infertility from the John Hopkins, Baltimore, USA. She is Secretary ISAR Jharkhand Chapter 22-24 and Joint Secretary ROGS 22-23. Thank you, ma'am, for joining us today. And our next panelist is Dr. Shweta Kumari. She is Consultant Ops and Gynae Sri Satya Sai Sanjeevani Hospital, Secretary Jamshedpur Ops and Gynae Society, Executive Member of Medical Disorder and Pregnancy Committee, is member of various organizations and has received various awards. Thank you, ma'am, for joining us today.
Thank you.
Next panelist is Dr. Shweta Mathur. Ma'am is an alumni of Lady Hardy Medical College in Safdarjung. She has been trained in endoscopy from AIIMS, New Delhi, and she is a secretary NOGS, past treasurer NOGS, and in clinical practice for past 20 years and visiting consultant in major hospitals in Noida. We welcome you, ma'am. Thank you for joining us. So I would like to hand over the session to our moderators for further proceeding. Thank you.
Yeah.
Thank you so much, Dr. Purnima, for that generous and kind introduction, I would say. And I thank at the outset Dr. Monica Singh and, of course, the entire team of Public Awareness Committee, FOXY, especially Dr. Rishikesh Pai, Dr. Madhuri Patel, Dr. Alka Pandey, and Dr. Priyankur Rai, the chairperson. I welcome the moderator with me, Dr. Basab Mukherjee. All of you know him so well. And yes, the panelists have been introduced. So straightway, without much ado, I think we will go ahead with the panel discussion. I hope you can see the slides and you can hear me well, right?
Yes,
so I don't think Madam Sonia Malik has joined. If at all, I think I welcome Madam.
Ma'am has joined.
Yes, ma'am.
Madam has joined. A very good evening, Madam. Pleasure to have you. Yes, always a pleasure meeting you.
Good evening, ma'am. Sonia, ma'am. Can you speak a few words, ma'am?
Yeah,
can you
please.
speak a few words?
Please
Yes.
go ahead.
Yes, ma'am.
Thank you very much. First of all, the Public Awareness Committee of FOXY. Thank you very much, Sneha. Thank you very much, Basab. Thank you, Priyankar. Thank you, Monica. So thank you, the entire team who has actually got this program together. We all know that this PCOS is also something which is close to my mind. I have always been associated with tuberculosis wherever I've gone. But this also is a very, very close part of me. I have been doing a lot of work in this as well. And thank you very much for having me here with you all. I think this is going to really enrich everybody who is here and tell us more about it as we go ahead. Thank you. Thank you all.
Thank you so much, Madam, for the wonderful insights into the subject. And with this, I just take this privilege to introduce the topic. Yeah. So polycystic ovarian syndrome, all of you know, this is one of the commonest, the endocrinological disorder we face in our day-to-day practice, yet the most neglected one. The incidence, all of you know that, it is varied, some quote it at 6 to 20%, some 3 to 5%, but definitely it's the commonest disorder of the reproductive age group. The incidence, whether it is a rural population or an urban population, it is almost the same, I can say, at least 2 in 10 adolescents, they are facing this problem. And as all of you are discussing that, yes, it can be obese PCOS, the most commonly discussed, though the lean PCOS having same features and of course the same long-term effects definitely is on the rise. May it be the undernourished urban population as well, and where the people are actually active. So the reasons being varied. So incidence is definitely on rise. All of you have been listening to it about the environmental factors, the endocrine disruptors, what we have been talking about, the changing lifestyle of the modern society, the junk food, the lack of physical activity, the sedentary activity, the academic load with less time for outdoor activities, and of course, the genetic predisposition which these women have, persistence of physiological hyperinsulinemia of childhood may also be the cause. So with this, I would just start with the first case, as Dr. Basab has asked me to, start. So I follow his orders, and yes, here we are. Dr. Anju, do we have Dr. Anju Kanujia?
Yes, ma'am. Good evening, ma'am.
Yes.
Slideshow.
Yeah. So can you see it? Yeah, now in full screen?
Yes,
yes.
yes.
Okay. So we have this 13-year-old girl with her mother. She's accompanying to the gynae clinic, and she has ultrasound report in her hand. The mother is very apprehensive about her irregular cycles. She has achieved her menarche only 9 months back, and the cycles are maybe 10 days earlier, or maybe once in 2 months, and the flow lasting for 4 to 5 days. Her BMI is 24. She's got mild acne on the face, and there is no other surgical or medical problems whatsoever. So she has the ultrasound report, suggestive of multiple follicles in both the ovaries. The ovary volume is increased. The uterus is normal in size and shape. So she's worried about this ultrasound diagnosis. So Dr. Anju, what is your diagnosis? and any other investigation you would like to do for the confirmation of the diagnosis here, how would you counsel the mother as well as the daughter?
Ma'am, good evening, ma'am. First
Good
of
evening.
all, I would like to thanks to all PAC committee to making me part of this webinar. And ma'am, I would like to counsel her mother that this is a normal part of pubertal transition, and I will try to teach her that period more than 1 year or less than 3 year post menarche, and of duration of cycle less than 21 and more than 45 days are normal, and more than 3 years post menarche to perimenopause, less than 21 days or more than 35 days or less than 8 cycle per year are normal, and more than 1 year post menarche, more than 90 days for any one cycle, primary amenorrhea by the age of 15 or more than 3 years post thelarchy. These are normal part of pubertal transition. I would like to counsel her mother कि don't be panicky.
Okay.
And
So
also
she's
I will.
worried about the various aspects, and first and foremost is the irregular cycles, and you have this very scientific explanation saying that yes, she does have
There is a lot
irregular
of
cycles.
noise. There is a lot of noise in this thing, no?
Yeah.
I think two or three people are logged in at the same time.
Yeah. So
Yeah,
I think
Dr.
the admin, can you please mute the rest of the
Dr.
delegates?
Sneha, you're not audible.
Hello, is it? Hello.
There is a lot of background noise from your mic.
Is it? Okay. Now can you hear me?
Yes, ma'am.
Let me just, yeah, yeah.
It's okay.
Yeah, so let's go on with the discussion. I think already Dr. Sneha has asked, Dr. Anju has given a comment. Dr. Arun, can we bring you in the picture? Till how would you counsel this person? Dr. Sneha, we're just taking the discussion forward. I've asked Dr. Arun, how will he counsel the mother and how will he take the case forward?
Already, Madam has, I think she has already answered. So I will just counsel that nothing to worry. It is a normal pivotal transition. Just do a hemoglobin. I like to do a hemoglobin to see whether she is anemic or not. If she is anemic, I'll just give some iron and protein supplements. So that's all what I am going to counsel this patient. And I will ask her to return after 1 year because it is within 1 year. So let us see after 1 year how her cycles changes. Then only we can further go ahead.
Yeah, but just remind me somebody that there's a recent ESHRE guidelines about 7 years after menarche, you cannot diagnose PCO with irregular cycles. There's something around that. Initially, we used to say 1.5 years, 2 years, 3 years, but now there's recently something coming up to 7 years in now post menarche. You still have to wait for some time to diagnose PCO through irregular cycles. Next slide, Dr. Sneha.
Sir, actually, that is for ultrasound.
That is for ultrasound.
Ultrasound, but we can
For
diagnose
ultrasound
PCO
diagnosis,
by
for ultrasound diagnosis.
ovulatory dysfunction and hirsutism.
Yes.
So that's still 3 years, right? It's not earlier than that. It's still there.
Yeah. So basically, she had the issues mainly on the irregularity of the cycles. And what about the acne? How do you counsel her whether her daughter has acne? Are they really significant clinically for the diagnosis of some abnormality?
It is normal. It's normally there is some degree of hirsutism that occurs during adolescence period.
Yes.
But we have to see how many acne are there, how many comedones are there. And if it is more than 10 only, then that will tell it is a hirsutism, clinical hirsutism. If there is a hair growth, then we should see whether it is a terminal hair or it is a vellus hair. The length is more than 5 millimeter or not. Then only we can tell it is a clinical hyperandrogenism or not. So it is difficult in this period actually. And if there is no clinical hyperandrogenism, we have to go for biochemical. But biochemically also, again, it is difficult because so many tests which are not sensitive. We have to go for free testosterone, androgen index, total testosterone. and all these things, and which should be measured in empty stomach, a lot of things, and should be liquid chromatography should be used, which is not available in all parts. So it is really difficult for diagnosis of a biochemical hyperandrogenism also. So it is really, in this period, it is very difficult to diagnose also. Periods are irregular, even in normal phases. So we have to go by the ISRE guideline, how is her periods and hyperandrogenism. And to coming ultrasound, as sir told, we cannot diagnose PCO before 8 years of menarche. Ultrasound cannot be taken because ovaries are multifollicular at this stage of life. So that's why this is a problem during adolescence.
Definitely. So irregular cycles, it can be just, as a part of normal transition. As you have rightly pointed out, the hyperandrogenism, even if it is clinically present, you have to actually score it by using the, various tools as we have it. If at all the clinical hyperandrogenism is not present, in that scenario, you can go for biochemical testing. And yes, definitely, there are also, you have lab-to-lab variations and all the complexities of the procedure as well. Pelvic ultrasound and AMH, they are not recommended for PCOS in adolescents. And as you have rightly pointed out, the ultrasonography is recommended only 8 years after the menarche, whenever you want to, diagnose the PCOS on ultrasound. So exclusion of other disorders that mimic PCOS is required in all these girls. And that's a very reason we have to actually go for various investigation. So to conclude, it is a normal transition. All of you have already said, and you have very well said that you have to counsel regarding the nutritional status of the girl. And of course, you have to, advise various supplementation for her growing age. Definitely HPV vaccination. This is the best time you catch this girl for, talk to the mother that this is the best time to go for HPV vaccination for this young girl. And of course, pap smear and HPV vaccination or HPV DNA for the mother herself as well. So that is how we can go ahead with, counseling. So over to you, Basar, if at all you have some comments. Otherwise, we can go ahead.
No comments. But if Dr. Sonia has something to say, adolescent PCOS,
madam.
Dr. Sonia.
Yeah. After
if you want to come in here,
you can come in whenever you want, madam.
Yeah, let me come in a little later. Let me come in a little later.
Okay, no problem.
So definitely. So we have this second case, 17-year-old girl, 11th class student. She presents to us with frequent cycles since last 6 months. And, she has joined some coaching class with her hectic schedule. And her menses, the cycle length varies from 15 to 18 days, very frequent cycles. The flow lasts for 5 days. She had her menarche 5 years back. And in spite of that, she's having this irregularity. There's no history of acne or hirsutism. Her weight gain is definitely significant, 3 kg in last 2 months itself. Her BMI at present is 26. Thyroid parameters are normal. There's no clinical evidence of hyperandrogenism. And of course, on investigation, her TSH is 4.2. Prolactin, FSH, serum testosterone levels are normal. Even a 75 gram 2 hours blood sugar levels, they are normal. What is your diagnosis, Dr. Joy Shankar, and how do you counsel or tackle this case? Do we have Dr. Joy Shankar?
In this case, the more or less all the investigations are more or less normal, and but the weight gain is significant. So we will counsel her to do some aerobic exercises and
so
try
whether it is a normal transition, whether it is a PCOS overt, or whether it is a PCOS at risk, how would you label her?
It is a normal transition.
What about the significant weight gain?
Significant weight gain is weight gain is significant, so we will counsel her to reduce the weight.
Yes.
And this lifestyle modifications has to be done.
Yes.
And few more investigation we'll have to do. That is although the testosterone is normal, but we can do the DHES, then insulin, serum insulin level to check for the insulin resistance. And we can also do the ultrasound to see if there is any other reasons for
We'll just say that unless it is 8 years post-menarche, we do not do the ultrasound for adolescents PCOS, right? She's just 17 years and she's only 5 years post-menarche. So she has got obesity, definitely the significant weight gain, but she doesn't have clinical signs of hyperandrogenemia, and even the investigations are almost in the normal range. But definitely, she is what is labeled as PCOS at risk. That means you keep a close vigilance on this patient, on this girl. Definitely, you need to monitor her from time to time. And yes, as you said, maybe if within 3 years of this diagnosis, whenever you are advising her the diet modification, the lifestyle modification, and whenever you're not observing any significant improvement, in fact, the cycles are getting more irregular, the weight gain is increasing, and now maybe she is showing the signs of clinical hyperandrogenism. So the full-blown PCOS may develop later, and that's the very reason you have to, keep this girl as adolescent with at risk of PCOS, right?
Yeah.
So
we have to keep watching her.
Yeah, Dr. Julie, how are you going to counsel her, and does she need any follow-up? That is what almost a few things have been discussed, but you can take this discussion ahead.
Good evening, ma'am. Thank you for giving me this opportunity today. So, so initially, of course, the most two significant points that we have is her irregular cycle, very frequent cycle, and her weight gain. So since it is too early to do ultrasound to actually know her ovarian status, follicular status, I think firstly we should help her in counseling and initial weight loss. So what I usually advise to my adolescent patients is that do an activity that you like. It doesn't have to be a burden on you. It doesn't have to be a certain thing that which feels like a task to the adolescent, because they are young and they like either join a tennis class or a badminton class or a dancing class or a aerobics class, something which
Dr. Julie, the problem is sometimes you ask them, they say that playing video games and watch Netflix series is, so that's
has
a
to be an
problem.
activity. They have to show that.
Yeah, physical
they are
activity.
sweating.
You mean with something which makes them sweat?
Yeah,
something which makes them sweat.
So exactly,
that
some
would be
sort
very
of
specific.
an activity which is related to exercise, like
absolutely. I guess you're right.
So that's what I was talking about.
Yeah. We all do that. We do that.
And about the diet, I think you should, but I mean, it's not that we should accept whatever they like to eat, and we should.
Yeah, so mainly his junk
tell
food.
them what is right and what is healthy for them.
So
how
what
would you
is
go ahead with the diet? Yes.
Yeah, main thing in the diet is that they love junk food. So what we have to avoid the junk food. We have to make them follow a low calorie diet, low carbohydrate and high protein and low fat is what, and high fiber is what we have to follow, ask them to follow. In fact, to help them out with a dietitian, they have to maintain a regular sleep routine, because nowadays on the phone they tend to sleep very late, and hence the whole cycle of the routine gets spoiled, and then that also increases the fat gain. And also nowadays anxiety and depression is very high amongst the youngsters, so sometimes the psychologist help also is required for them to understand where their weight gain is coming from, and if there's any other issue which is make them binge eat or just sit and have a sedentary lifestyle at such a young age.
So just one question, Dr. Julie, if you can come in here and just have a practical touch on this. How many patients in your clinical practice have benefited from lifestyle modification in PCOS? Means the very short answer is, like, for me, it would be 10% or less.
Yeah.
Yes, we do talk about them, we always do the discussion which you made. It's absolutely the correct discussion to make.
Right.
But how many people at the end of the day do that? And about the psychological aspect, I think one of the things which a lot of PCO people talk about is that one of the reasons why they get psychologically upset is because of the doctors. The doctors, the way they put them on the weighing scales and they say that you're not losing weight, you must be eating, you must be cheating, this is not the way, you can't do this, and that's why they get upset. So the psychological aspect as part of it is because we label them as not following orders. I think that's something which we should all be, I think, as clinical practitioners, be careful about.
That's the reason I feel that I said that we have to ask them to do something they enjoy doing.
Absolutely, you're right. You're absolutely
Because
right.
if I tell them no, you can't, you have to stop eating and you have to go start exercising, do this exactly as I'm saying, so that's something they don't feel very comfortable with and they don't listen to you. So when they're very young, we, as we said, that we cannot the ultrasound is very inconclusive, so we cannot diagnose on basis of that. So only thing we can, because most of the PCO patients that which I am getting adolescent who are overweight, they have the inclination towards junk food, and they have the inclination towards sitting and playing games, or either on video games or on mobiles. So I think it is just the mindset we have to change rather than making it a punishment for them. And I think the counseling part, how we talk to the patients, because they're very sensitive at this age, I think that's the key to making them understand what they have, and actually convince them to lose some weight for their own benefit.
Yeah, I agree with you. Dr. Sneha,
yes, yes. So I think definitely these are all practical issues what you have been talking about. I handle a lot of obesity, and adolescence is very close to my heart, and I have been practicing all this. But definitely, you talk to them empathetically, you show them the practical results. For me, they always, ma'am, how you keep yourself so fit. That is how, it's a positive motivation, I would say. So definitely I talk to them at a personal level and make them do what, like we share with each other. I think that's a way you can take along these adolescents, because all of us do have the younger kids which we have nourished, and definitely our experience also will count. As you have said, yes, you cannot make them force, and but diet modification and active physical exercises, maybe every time you encourage them and you make them feel that yes, definitely something has become better. I think that's a way of going ahead. And as this is the chart just showing, just it's not only exercise, but having some active physical activities, whatever little you can do. And yoga definitely has a place, because all these muscle stretching, muscle relaxation, and holding the weight bearing asanas also, so many other things, they definitely help for it. Diet, I think we have talked about it. The only sentence here I will say that it has to be individualized, how much calorie requirement they have, and how the spread they should choose. As you have already said, low carbohydrate and low on fat. Also, definitely protein should be high, the fiber should be high, and fruits and all those things, should be in ample amount. There should be no sugary juices, no junk foods, and definitely it has to be accompanied by the active physical exercise. So with this, I think it's Sonia, madam. Yes.
Yes, please.
Yeah, Dr. Sonia would like
Yes,
to
yes,
come.
I'm going to invite her.
Yeah.
Already.
So thank you, Sneha. Thank you. Those were two very interesting cases to the topic
Sonia,
of,
please
I mean,
carry
what
on.
you have can you hear me?
Want
I
to
don't
hear
know today my
Yes.
this thing. Anyway, the term that you have used, at risk PCOS, that is something that is coming up very well. And even in the new guidelines, as Basa was saying, they have mentioned about the risk factors and where you have to really be very careful and assess them for risk factors. Even in the Indian guidelines that we made in 2014, we were talking about the risk factors in adolescents. And definitely, obesity is a very big risk factor, as you have mentioned in one of your cases, you have that patient whose only feature was obesity. She was showing irregular, excessive bleeding intermittently, but she has suddenly gained a lot of weight. So these are features of patients who will ultimately turn out to be PCOS if you don't follow them, and hence it's a warning sign for us to know that we have to catch them young, and we have to follow these girls and see that they don't pass on to the next stage. What is also important in these adolescents is that we have not touched upon with obesity is metabolic syndrome, complete full-blown metabolic syndrome that many of these young girls are presenting with, and their obesity and hypertension with diabetes is something that you all have to watch out for. So if you have an adolescent who is presenting with PCO-like features, she is obese, please get her blood pressure checked at least in the clinic, so that that she's not having that. There have been 2-3 studies from India, one from Chandigarh, one from the south, which have shown us that there is a very high incidence of metabolic syndrome to the tune of 10 to 13% in these adolescent girls, in school girls. So please always be aware of even checking out for the waist-hip ratio, for the diabetes, for the hypertension in these patients as well. Let us move on to the next case now.
Thank you so much, madam, for your expert and experienced comments. And definitely taking this ahead, as per the age we are going through the spectrum. So we have this girl, same girl, presenting after 10 years to you. She's now 27 years, and she has a hectic job profile, or working for almost 12 to 14 hours a day. And she followed the weight loss, especially when they are going to get married or something, they try and lose the weight and follow all your advice, and the things are settled, cycles are regular. Now after some years, now she gained her weight again, her cycles are back to irregular. Now she complains of delayed menses every 50 to 60 days with slightly heavy flow. Her BMI has increased to 28, and she has developed features of hyperandrogenism with terminal hairs on the upper lip, chin, and few hairs present on the lower abdomen, chest, and thighs. Acne has also developed. The patient is very conscious about her look. So on examination, her hormonal profile, what is done is normal. And Dr. Poonam, do we have Dr. Poonam here? How would you manage this patient, Dr. Poonam?
Good evening, ma'am.
Good
Thank
evening.
you for
Good
the
evening,
opportunity.
Yeah.
Good evening to everyone. Yes, ma'am. The patient here, typically the patient is presenting with PCOS. And the fact is now again, she is gaining weight. Her cycles are irregular. So the major concerns are, as has been written, her hyperandrogenism, hirsutism and acne, because she is apprehensive for her looks and her irregular cycles, her insulin resistance, whatever is developing over her, the terminal hair and the pigmentation and other things. So these all have to be taken care of, and proper PCOS counseling, reduction of the weight, and management with medications like before proceeding.
What investigations you would like to go for, Dr. Poonam?
Yes, ma'am. The
Importance of
investigations
each. Yeah.
Yeah, investigations are for the hyperandrogenism. We will do serum androgens and SHBG level, LH level. Her LH level on day 2 or day 3 of the cycle, 17-hydroxyprogesterone, ACTH level. We would go for free testosterone, total testosterone, dihydroepiandrostenedione, and a free androgen index, as has been, and dihydro testosterone. The fact is that we would also go for the free insulin levels, also fasting insulin level. And yes, this is the way we'll proceed. Of course, the ultrasonographic assessment of PCOS.
What is the reason for doing so many investigations? Are we really, are we suspecting PCOS, or are we suspecting something else as well?
Yes, ma'am. We are suspecting something which is causing hyperandrogenism also. Maybe some separate cause. That is why we are going for the androgen level, free testosterone and other things, and maybe something related to adrenocortical syndrome sort of things, like her adrenals may be hyperactive. And the other thing that we also have to rule out the insulin resistance there. Maybe she may develop in future something related to diabetes. Maybe she will develop the diabetes. So free insulin, that is this insulin resistance has also to be ruled out.
And one more reason being the PCOS is a diagnosis of exclusion, especially when you have such a severe hyperandrogenism. You may better exclude the other causes of hyperandrogenism. So how would you manage this hirsutism now? What are all the modalities and how would you tackle it?
Exactly, ma'am. The hirsutism is to be managed like I am an aesthetic physician, a cosmetic gynecologist also. So these days, shaving, waxing are now no more in the vogue these days. Bleaching, electrolysis, lasers are very famous, very common. Patients are demanding themselves for lasers. So diode laser for hair reduction, we do in our clinics. And also we can go with the hormonal therapy where we start with the contraceptive pills, oral contraceptive pills. High dose progestins can also be added just to lower the free estrogens which are there in the circulation. And we can also go for dexamethasone for adrenal androgen suppression and peripheral anti-androgens, spironolactone, cyproterone acetate. This is in the combination with estrogen. This is very commonly we are prescribing as an anti-androgen progesterone, which is added, and cimetidine also. Total androgen suppression can also be done with ketoconazole, though I have never used it separately for androgen suppression. And reduction of insulin resistance, they are metformin. Yes, we are using this. Triglitazone, roglitazone are also mentioned, but basically I don't have that much of experience like using them separately. And laparoscopic ovarian drilling where the intractable PCO cases are there.
So Dr. Poonam, can you inform for the audience and for all the people who are listening, the use of laser diode therapy for hirsutism, is it a permanent therapy? How long does it last? And if you can just give us some information on that.
It's a very nice question.
Appropriate question for Dr. Poonam.
Yes. Thank you, ma'am. Thank you, sir, also. And yes, this diode, that is why we ask it LHR, laser hair reduction. This is not removal. This is not a permanent removal of hair. There with diode 810 wavelength we are using, and that actually reduces the hair growth. That is why the hair in crops, they go out. First, the
but
hair.
I thought just correct me, the laser is for destroying the hair follicle, or no, it's not that. It doesn't work on the hair follicle. What does the laser go and act on?
It acts on melanin. Melanin is the proper that is why white hair don't go with this laser. So the hair in the shaft that goes first, and then the laser acts on the follicles. So once the follicles are destroyed, the hair follicles are not going to give another crop again. But yes, it takes multiple sittings, and with multiple sittings like 6 or 8, 6 or 8, we just make the clients understand in a way that in a city when the enemies are there, so we just come and there is a battle, and those who are in front are gone. So once again few are coming, then the next sitting will destroy them all, and then whosoever are there in the reserve inside the you can say in a kile ke andar, those who are there in the reserve form, they are also destroyed in the next sitting. So this is the way we do with laser, the hair reduction. And yes, it lasts actually. If the perfect hair reduction is there, it lasts. And further hair growth is just because of abnormality in the hormonal part. The hormonal activation is there because PCO persons, they actually re-aggravation of the symptoms are there, and the hormonal levels are there, disbalanced hormonal levels are there. So their top-ups are needed.
Thank you.
So
Thank you, Dr. Poonam. We'll move forward.
Thank you.
Yes.
Thank
So
you.
cutaneous manifestations you have tackled very well, Dr. Poonam. Now we come to the weight reduction part of it. how much should be the weight reduction to be effective to correct the menstrual cycle, and how it can correct your reproductive cycles as well. So Dr. Ranjana, can you throw some lights on the weight reduction part of it as far as the lifestyle management is concerned?
Good evening, everyone. And first of all, thank the organizers for giving me the opportunity. I say my patients, even 5% weight reduction is beneficial for you. It helps in ovulation also. It helps it helps in so many ways. It decreases insulin resistance. It also increases serum hormone binding globulin. And so even 5 to 10% weight reduction is sufficient for these patients.
Okay, so the SHBG, the sex steroid hormone binding globulin, that is, that level increase synthesis from the liver, and thereby the free hormone levels, goes down. That's how the manifestation of hyperandrogenism also goes down, and the cycles are regularized, and they regain their ovulation as well. So very well discussed, Dr. Anjana. I would just ask you, what is the role of cyproterone acetate, if at all you can throw some light on this, and what is the dosage, or what is the way you use in your practice?
Alone cyproterone, I am not using. I am using with combination of ethinyl estradiol. In the name of Juliet 35, I am regularly using, but alone cyproterone I have not used.
Correct.
But if it used, it can be used in 100 milligram per day. 25 to 100 milligram it can be, but I have never used.
Okay. So the routine combination, what we are using, Tronispi and all those that
no, they're not drospirenone, cyproterone.
Yes,
Dr. Ranjana, if you can.
OC pills
Dr.
containing progesterone with anti-androgenic activity such as drospirenone or cyproterone acetate. But I am preferring cyproterone if there is features of hirsutism also.
Yes.
Yeah, correct. Dr. Ranjana, just one point I wanted to ask you is that how many cycles of cyproterone can you give? There have been some concerns about giving cyproterone for a long duration of time, and some people limit it to 6 cycles. What do you do in your
I have not used more than 6 cycles.
Yeah, I think most of us do that. I think we'll agree with you. If you need to use it longer, you shift to drospirenone.
No, I have not used.
Lesser hirsutism, a lesser anti-androgenic factor, but still that would be safer. Yeah, Dr. Sneha, please.
Along with OC pills, I am also giving them to metformin and myoinositol combination, also vitamin D also.
Sensitized.
Yes.
I'm sure it's later in the presentation. Yeah. Dr. Sneha.
Yes. So what is the role of COCs, you feel, whenever you are prescribing COCs? What do you feel? Yeah.
Yes, it is the most commonly used because it regularizes the cycle also. Most useful drug is this, and it also increases the level of serum hormone binding globulin. That's why it reduces the free androgen level also, and that's why it decreases the androgen concentration also. So this is the most commonly used drug in PCOS.
So it regularizes the cycle.
Yes.
It controls the bleeding during menses. And
which is most
also
common.
because, it doesn't allow the unopposed estrogen action. The
it also helps in
proliferation is also halted, and that is why the long-term effects on the endometrium. And what Madam was talking, even later on we are coming in the discussion, the metabolic syndrome, because we are regularizing and we're taking care of the hormonal imbalance in total. So Dr. Sakshi, how do you correlate the hyperandrogenism with this insulin resistance? Dr. Sakshi, do we have Dr. Sakshi?
No, I can't see her.
No, I think anybody can take up this question. We can start from the beginning. Dr. Arun.
When there is insulin resistance, it will cause hyperinsulinemia, which will act on the liver, and it will decrease sex hormone binding globulin, and so there will increase androgen activity. This is the cycle concentration.
More of hyperandrogenemia.
Yes.
Hello, can you hear me?
Yeah, we can hear you, Dr. Shweta. Please carry on.
Yes, sir. This is the relation. It is the more insulin resistance is there, there is more hyperandrogenism also associated with that.
Absolutely. Yeah, that's
so,
right.
So both
because
needs
of
to be
this
taken.
hyperandrogenism, the higher levels of androgen, again the LH is high and it acts on the theca cells of ovary. So it acts as a vicious cycle. So that is how. What are all the insulin sensitizers you all are using in your practice, and how does it help?
So, ma'am, metformin
Uh,
is my preference. The first
I use
preference is metformin.
combination of metformin and myoinositol. I use combination of both.
Myoinositol and chiroinositol combination comes, and then metformin can be given separately.
Actually, according to guideline, metformin is only indicated, and bioinositol, dicarianositol, or all those are can be used in research setting. In the context of research setting only, we can use bioinositol because that has not been that is not a pharmaceutical drug. That is a nutraceutical. So you can tell
Yes,
that is a adjuvant drug actually.
Yes.
So Dr. Arun, in the latest X-ray which we had gone, they were a little more liberal on
Yes.
myoinositol and decairo. Because
Right.
what you were saying is what we used to say before, but
Yes.
now they have got more studies. But as you rightly said, it hasn't come into the guidelines, but they have become a little more liberal that you can use myoinositol. But again, all of us in our clinical experience use it, but little studies have been done. As you rightly say, we have to wait for more studies on decairo as separately and as a combination with metformin, as Dr. Ranjana uses. I also use very commonly as a combination,
Yes.
but again, we haven't much of evidence backing it to say that it is better than metformin alone. So what Dr. Arun says is actually right, that metformin is the most tested and definite things. But myocairo, I think Dr. Sonia will bring you in here.
Yes, yes.
The
I think
myocairo,
there is a lot of evidence also, because even we have the Indian study by Dr. Hema Divakar and all those people. It's a huge study, and definitely Madam will throw some light on this aspect.
this is an eternal discussion, Dr. Sonia. Whenever we discuss PCO, the company drive and the company motivation is so high. The industry has fed everybody that myo and chiro has to be
Myo
used
and decairo.
somewhere has to be used in PCO. So if you can just share your thoughts on it, Sonia.
Thank you so much, Thank you so much. You see, the problem with I would liken it to something like insulin resistance. Now, we know that insulin resistance is there, and yet the guidelines are not talking at all about about testing insulin. You know, it's something like that for myoinositol also. We know that it is helping, and yet we don't want to acknowledge it, because we say we don't have enough evidence. So that is something which is causing a little bit of a problem. Actually, the problem is that there are certain areas in medicine where you really cannot do anything because it's so difficult to get evidence-based guidelines. And we also know now that everything is not evidence-based medicine. We have realized it, that evidence needs to be created. And therefore, until and unless we use something, how are we going to create evidence is my question. So therefore, it's a it's a difficult situation. So what we are doing, and like you very rightly said, the new ASHRAE guideline does say, although there is not enough evidence to say that it is helping in PCOS, but there is no harm in using it because it doesn't have side effects. You see, it's something like a provitamin, so it doesn't have any side effects. So maybe we are really deficient in anisitols, and therefore, if we use it in these patients, it may be of some benefit to us. But having said that, there are enough meta-analysis coming out of Italy. I do not know why Italians are the only ones who become very fond of myoinositol and chiroinositols, because I do not know why, but then they are coming out with the most highly rated meta-analysis on this subject. And I'm sure in the next guidelines, PCO guidelines, we will have them in there. So I don't think we are wrong in it, because you can remember very well that when we started talking about what do you call metformin also, when we
This
started
also ASHRAE said should be
not to use this, that. Now slowly and slowly they are mellowing down, and they are allowing us to use it for everything. So guidelines keep changing with the evidence, and I think we are not on the right track. That is my own perception of it. I think we can use it safely, because basically we are not harming our patients by using it.
Absolutely. Thank you, Dr. Sonia. Let's watch the space, I think is the word.
And one more thing
Watch the
I
space.
would like to add. Because if the patient comes to you and you will only advise that lifestyle modification and will not give her any medicine, she will not be satisfied.
Yes.
She has come to you to
Yeah.
get something. So
But you have an
that
option of giving her vitamin B complex. You have an option of giving her vitamin C. You have an option of giving vitamin D, Dr.
Yes.
Shweta. You can give her different other things also. If you want to give her placebo, it may not be a costly placebo. It may be a very cheap placebo. But
why this?
Insulin sensitizer, that is one, and reduction in the androgen levels, which is definitely proving up. So I think it should come up soon, as Madam has said rightly.
Correct.
Some patients also can have gastrointestinal intolerance to metformin. So those are those patients also we can give them bioinositol in a good way.
Yeah.
So now, why are we concerned so much about this PCOS? Here comes Madam Sonia's point. We have to really catch them young to avoid all these complications. So Dr. Shweta Kumari, I would ask you, what is metabolic syndrome? How do you come to the diagnosis of metabolic syndrome? And yes, Basab?
But we all like to give something more.
Hello.
He's lost.
I think Dr. Basab's network is a problem. Yes.
Yeah, I'm not getting a good.
Yes, Dr. Shweta.
Yes, ma'am. Actually, when a patient suffers from PCOS for the long time, then she develops the metabolic syndrome. Like the madam has said that when she has come, we should do general examination. We should also check her blood pressure, her blood sugar level, and also because she is more prone to develop um, hypertension, diabetes mellitus, hyperlipidemia. Lipid profile should also be checked. And accordingly, if there is, we are seeing like if she is suffering from hypertension, then she should be treated. If she is suffering from diabetes, she should be treated, because simultaneously all these will lead to more metabolic complication later on.
Okay, does now we have been all the time talking about high BMI. Does obesity really affect PCOS? Do we need to treat it? How do you
Ma'am,
cope with
actually,
obesity with
there are
PCOS?
two type of PCOS: lean PCOS and obese PCOS. So, if the patient is obese PCOS, then some of the drug companies come with two doses of drug, like Epicot obese and Epicot plain. So, we need to treat it accordingly. So, if the patient is obese, then definitely weight reduction is going to help her, and we should
No. The
advise her
question
that.
is, does obesity affect PCOS? If your patient has obesity, and what are the problems associated
Yes,
with
ma'am.
obesity? That
If
is what here.
Yes, ma'am, it is going to affect her, because definitely when she will reduce weight, then her metabolic complication will also reduce and her symptom will also get improved.
Okay, so once again, we give the message that should we screen all the adolescents with PCOS, diagnose PCOS for metabolic syndrome?
Yes, ma'am.
Definitely. Dr. Shweta.
According to the general examination, we can plan her investigation.
Yeah, Dr. Shweta Mathur.
Yeah.
Can you comment
Thank you,
on
ma'am.
this, please?
Can you hear me? Thank you, ma'am.
Yes, definitely.
Yeah. Definitely all the adolescents need to be screened for something to catch them young. So first of all, mostly weight is taken in the schools for the adolescents. So we should extend taking a weight to a concept of BMI for the first screening. So if screening should be something which is applicable to everybody. So first weight measurement and extending it to a BMI measurement and telling them what the ideal BMI is, and screening them for their activities and their healthy lifestyle. We should train them, and all the obese people, girls or boys we catch, we should screen them further with a blood pressure measurement, with a family history. If they have a history of diabetes or hyperlipidemia or something, then we can go to the extent of suggesting a blood test for them. But I think basically weight measurement, blood pressure measurement is the first thing which should be screened. And all those we find to be on high risk on history, like family history or irregular cycles or severe acne or lot of hairy girls, they can be further tested to the sugar fasting and lipid profile. But I think we can extend to BMI definitely.
You have explained how to screen, but the reason being 5% of these adolescents, they have metabolic syndrome. And almost 37% of PCOS adults, they develop meds in future. 63% of obese PCOS adolescents, they already have metabolic syndrome. So hyperandrogenemia, obese PCOS, these are the risk factors for metabolic
syndrome.
Yes.
So if we screen more, basic screening we should do for everybody. That is, the concept of BMI should be introduced, and later on, whoever finds fits to be a obese one or PCO one can be further tested for metabolic syndrome.
So fasting glucose level, the lipid profile, and blood pressure. So we will be coming to the criteria for diagnosis of the metabolic syndrome, definitely. And we are coming to the last case now. So Dr. Anju, back to you once again. And with this case, once we finish, we will have Madam's expert comments after this. 42-year-old lady, she's complaining of irregular periods, menstrual periods, and mood changes, thinning of the thinning hair on the head, almost getting bald, excess hair on the face and body. She's unnecessarily gaining weight, and she's going into depression. So is it only the perimenopausal syndrome, or it is only the normal perimenopausal transition, or is it perimenopausal PCOS? And why should we evaluate, and how should we evaluate this lady? Dr. Anju.
Yes, ma'am. There may be both possibility. It may be due to perimenopausal transition, or might be due to PCOS changes. So this age group is very prone for atherosclerotic cardiovascular diseases. There is sevenfold increase, and these age group, these patients are more prone to diabetes mellitus also. So, ma'am, both things should be evaluated.
Yeah. Hello, can you hear me?
Hello. Yes, ma'am.
Yes. So how do you define metabolic syndrome, and what all things you should measure?
Ma'am, there is
Can
criteria
somebody
for
just say
diagnosis.
it, or should I?
Hello. Hello. Am I audible? Hello.
Yes, you are audible. You are audible.
Yes, ma'am. Ma'am, there is elevated waist circumference more than 102 centimeter in men and more than 88 centimeter in women. Elevated triglyceride more than 150 mg per deciliter, or drug treatment reduce SDL-C less than 40 mg per dl and less than 50 in women. Elevated blood pressure more than 130 mm of Hg systolic and more than 85 mm of Hg diastolic, and elevated fasting blood sugar more than 100 mg
So
per
at
dl.
least the fasting blood sugar of more than 100 milligram percent and the blood pressure of 130 by 85 millimeter of mercury. These are the two criteria you can definitely have. And as you have rightly said, that the HDL cholesterol, if it is less than 50 milligram percent in women, then she is prone for, she's already going into metabolic syndrome. And her waist circumference, if it is more than 88 centimeter, then it is, she's going into metabolic syndrome, or she's developing. So how to measure the waist circumference also, that you have to know that, you have to select the point on the iliac crest, and then you take a horizontal plane at the level of iliac crest. Ask her to take deep breath, and then at the end of the expiration, you're supposed to measure. So definitely you have to measure it, parallel to the ground. That is how it has been, measured, and then you fulfill the criteria for the metabolic syndrome. What are the impact of NCDs? Can anybody comment on this? And then I think we will give the message. Yes, anybody? What are the impact of risk factors on NCDs?
Ma'am, when the patient is having metabolic syndrome, there is high risk of within next 10, 20 years, there is high risk of developing over diabetes, having heart diseases, and all these are the two most important things which it tells. And with the increasing weight, the patient will tend to have psychological issues.
Yes,
And
some of the
with
mental
PCO patients,
disorders.
they have
Yes.
got higher risk of endometrial cancer. So, like that.
Yes.
So many risks increase.
And the unhealthy activity or diets and sedentary activity will definitely enhance all these risk factors. So eat a diet full of non-starchy vegetables. I have initially told you about this, that you first see that you are consuming the recommended calorie allowance for you, your age and height. And of course, you select your spread, how we have discussed already. So each diet full of non-starchy vegetables, whole grains, lean meats and healthy fats. Incorporate cardio and strength training exercises into their regular life. In fact, other than exercise also, you keep yourself healthy and active by doing your acts by yourself, as we have talked there, that you park your vehicle away from the entrance. Maybe you get down from a bus one stop earlier. Do not use lift or remote for your TV. So that is how get quality sleep. Do not use much of screen. Try hormonal birth control pills and diabetic the medicine for diabetes and hormone therapy. So all this you have to actually set the goals for therapy in PCOS. All these clinical features, and you have talked about weight reduction and regaining the cycle regularity, and of course the reproductive outcome to be at its best. That is how you have to manage PCOS. And for this, not only gynecologist and obstetrician, but also a general practitioner, endocrinologist, the dermatologist, the fertility specialist, as you have rightly said, mental health specialist, and the allied dietitian and exercise specialist. All these, you need to discuss all this. So, do we have Dr. Basab here? Otherwise, we can just have Madam's opinion. I will just project these two posters, which are, prepared and presented by Dr. Rakesh Singh, who is a FOXY Endocrinology Committee Chairperson, and she has made this available on the FOXY website. This is a perfect algorithm you can, use for your day-to-day practice. This is very, very helpful, and this is available on the FOXY website. And with this, I stop my sharing my screen, and I invite Madam Sonia Malik for her inputs and expert comments. So over to you, Madam.
Thank you. I think most of it has been said by you, Sneha. It is basically, we have actually gained a lot of understanding into this subject of PCOS. What we initially thought was just restricted to the ovaries, our understanding has now increased, and we understand that this is a disease which is affecting most of the organs of our body, and therefore we have to really take care of it. It's just not an endocrinal disorder which is affecting the ovaries and reproduction. It has many more ramifications, and therefore as we have discussed today, we have to start looking at it right from adolescence and then go on to menopause. We have actually taken the whole journey of this lady right from adolescence to menopause and tried to find out how and when we can help her. And as we have seen, what Sneha has actually emphasized upon is lifestyle management and, basically exercise and diet. That is something that we all need to be taking care of. Now, interestingly, I would also like to add to this, one of the most prestigious and much rated study that is carrying on still in our country. It was started 26 years ago in the districts of Pune. And it has transcended 3 generations. It was started 26 years ago when India was not so popular, was not so rich, and the population in that area was poor. And so what they found out was that most of the children were born undernourished. They had no problem. Mother was also fine. Everything was okay. IUGR was there, but it was controlled. And then as the affluence began, as we started getting in more money into that area, People became lazy, they became obese, their diets changed, everything, their lifestyle changed, and they found that gestational diabetes increased in that community, and they started getting, the large for dates babies. And after that, once the babies were born, there was a change, and then the babies became shrunken or smaller in size. Now, in the third generation, the amount of diabetes has increased. As we are also saying, we are seeing Foxy going after diabetes like hell. And all the women had, most of the women started getting gestational diabetes. There was IUGR in the babies. And after that, once the babies were born, then they were overfed because the indulgent mother and grandmother thought that the baby is chota, usko zyada mota karna hai. And with that, the changes in the longevity of the child, of the human being, has decreased. More heart disease, more chronic illnesses. So Barker's theory is coming out right, that we are noticing in our own country. This is a huge study which has traversed so many generations now, and that is why it is our responsibility as gynecologists to look after our mothers, to look after the children who are not yet born, to look after the coming generations that we are going to have. Hence, PCO is a very, very important part of our subject and of our responsibility. So we really have to take care that our girls do not go into that stage where they become very bad PCOs and can have no return after that. So thank you very much, all of you, for being here. Thank you very much for giving this opportunity to me. I have really enjoyed the discussions. Sneha has actually taken you through the journey of a woman. Thank you so much. Thank you very much.
Thank you so much, madam,
Thank you,
for your
Thank you, Monica.
wonderful insights and, of course, a very long experience. We are really privileged to have you as our expert for this panel, madam. Thank you. I think Dr. Basaf has got disconnected, but I would like to thank Dr. Basaf, my dear friend, and I would like to thank all the panelists. I'm sorry I could not take all of your names, but definitely a very interactive panel, a very knowledgeable panelist, and definitely you added value to our discussion. Thank you so much, dear all. And over to you, Dr.
Thank
Monica.
you, ma'am. Thank you for giving me the opportunity.
Thank you, everyone. And at the outset, I would like to thank Dr. Sonia Malik, who has joined today as expert. I mean, she has inaugurated my Symbiosis series because I have been after her life since 1 year. For question, for genital.
Monica ma'am, just one request, ma'am. Hello,
Yes.
Monica ma'am.
Yes, please.
Just can you just within 1 or 2 minutes just tell us the phenotypes of the PCO? There are more phenotypes nowadays. Earlier there were 3. So just
sir,
outline.
the Encyclopedia of Phenotypes is sitting in front of us, Sonia Malik ma'am. But I would just, before she comments, I would just like to, just revise my knowledge with you all, that we have 4 phenotypes of PCO nowadays, which have been, 2018 consensus has given us. The phenotype A is the full-blown PCOS who has hyperandrogenism plus ovulatory dysfunction plus a polycystic ovarian morphology. So this woman is very hard to treat because she has all the 3 features. Second is phenotype B, where in the polycystic ovarian morphology is not there. You will find normal ovaries, but she will have hyperandrogenism and ovulatory dysfunction. Both these features. She is phenotype B. The third is phenotype C, which is the ovulatory PCOS. Here, she is ovulating normally. She doesn't have ovulatory dysfunction, but she has hyperandrogenism, plus she has got a polycystic ovarian morphology on ultrasound. And last, the mildest form is the non-hyperandrogenic phenotype, where this woman does not have hyperandrogenemia, but she has ovulatory dysfunction, irregular cycles, and you will see the polycystic ovarian morphology. So the phenotype D is supposed to be the mildest. The phenotype A is supposed to be the, the toughest to treat. The phenotype C is supposed to be the leanest. These patients are having regular cycles, so they are lean. The hyperandrogenic lean PCOS are the ones which will benefit from PCO drilling. And the overweight and the obese, the maximum obese PCOS are the phenotype B. And now I request Sonia ma'am to please throw light. And madam has got a beautiful paper on the PCO phenotypes, which she has written. And I'm
I,
sure Madam will
Monica,
give
I
us.
think you're mistaken. I haven't written it, but of course, there's a very interesting paper from India, which I'm very proud of, which four of
But
our
ma'am, it
friends have
was
done.
S. Malik. It was S. Malik and people from Delhi. So I thought it's your paper.
So that was the guidelines, Monica. You're mistaken
Okay.
with the guidelines.
Okay.
The paper, the original paper that was actually Dr. Mahajan, Dr. Nalli Mahajan, Dr. Madhuri Patil, Dr. Sujata Kar, and one person, I don't remember who it was. Four of these people from different parts of the country, north, south, east, and west, they did this study, a multicentric study, which was published on the type of phenotypes that are present in India. And very interestingly, Monica, as you have stated, the most difficult PCO, that is type A, is the commonest PCO that we have in all parts of our country.
Yes.
So unfortunately or fortunately, Dr. Arun, we have this privilege of dealing with the most difficult PCOs in this country. And also, I would like to state that besides these four phenotypes, we have multiple combinations of phenotypes in our country, where one or two will be just mismatched together, and you ultimately have not just four, but they have stated 9 types of PCOS, depending upon the classification that we use, whether we use the NH classification or we use the Androgenic Sex Society classification or we use the Rotterdam as we are doing. So depending on what has been used in the different studies that have been conducted, we are finding these multiple PCO. That is why we are in such a bad situation. We really do not know what we are dealing with. And just as Neha put up the second case, that was a different phenotype of a PCO. She was not having any other feature except obesity, and she was having irregular periods, but to a different sort, different kind. Not that oligomenorrhea. She was not having anovulation because of oligomenorrhea, menorrhagia with oligoovulation. So these are different phenotypes that we have. But like Monica has very nicely pointed out, those four are the major phenotypes that we have to be really careful of. And interestingly, when you look at the ovaries of these PCOs on ultrasound, the ovaries are going to tell you what kind of a PCO it is. If this PCO is hyperandrogenic, her ovaries are going to be large with a lot of stroma in it. Of course, the peripheral pattern will be there. And on Doppler studies, you will find that there is very little blood flow through the ovaries. These are the ones who are going to be resistant to clomiphene, resistant to whatever you may do with the high AMH, nothing is working at all. On the other hand, the mildest form that Monica has told you about, where the PCO is present, but she is ovulating. These are the ones who have a luteal phase insufficiency and the ones who are tending to have recurrent miscarriages. So here, there is a different problem. The follicle that is formed is not good, and hence she is not being able to retain that pregnancy. So she will present to you as as recurrent miscarriage. So that is how the ultrasound also helps you to identify the PCO phenotype. Although we know that now these new guidelines do not say that you don't have to do an ultrasound in order to diagnose a PCO. If you have two features already present over there, you don't have to do an ultrasound to say she's a PCO. But of course, where you don't have two features, then you have to use the ultrasound to see what is the morphology like. Right? And one more word about the postmenopausal lady. In the PCO, the menopause guideline, Indian Menopause Society guidelines, when you find the chapter on PCOS, it has been very interestingly discussed over there that if you have not seen this patient before, like the case that was presented today, where she's having irregular periods and she's having all those features, if you do not know that she is a PCO beforehand, then at menopause, you cannot diagnose her as a PCOS. Why? Because she's having irregular periods as it is because of her menopause. And also, she may be hyperandrogenic because of her menopause. It may not be because of PCOS. It may be just because she has more testosterone now in her body because of menopause. Estrogens are gone. So hence, it is very difficult to identify a PCO unless she is not already identified. You will not be able to fit in those two criteria. So these are new learnings that we are finding from as literature is evolving, and hence we are all the time discussing these things in our webinars and in our conferences. Thank you very much.
Ma'am, for ART people, it is important. For those of you who are practicing ART, the hyperandrogenic phenotypes, are the ones which will lead to lower IVF results.
Absolutely.
Your live birth rate, your clinical pregnancy rate, and your cumulative live birth decrease in proportion to increasing hyperandrogenism.
Absolutely right.
Ma'am,
Absolutely. You will do whatever you want to.
Yes,
ma'am, what about the ultrasound features of polycystic? Means ISRA guidelines tell 18-20. We are using 12 earlier. So what
Now
we
it is
use?
the
Number one.
2023 guidelines, which are published, the latest international evidence consensus, which has been compiled by the Australian National Health Society, along with 5 continents doctors. It says that the ovarian volume has to be more than or equal to 10 centimeters cube, and the follicle number per ovary should be more than or equal to 20.
20.
Each
Previously it was 12, now it is 20.
So again, Monica, there is a rider over there. In India, every gynecologist does not have those high resolution machines where the vaginal probe is more than 7.5 megahertz. We have usually the 7.5 or the 5.5 in our country. So here the old criteria of 10 to 12 continues. It is only in those very, very high resolution where the frequency is much more. It is only in those patients where you require to, have this kind of a thing of 20. That was given in the previous guideline, not in this particular guideline, in the previous guideline, where that also suggested that the format of the report should mention what kind of a machine has been used to diagnose this PCOS. That was something but very good. What machine have you used? What is the frequency of the probe that you have used in order to diagnose the PCO? That was mentioned in the earlier guideline. This one doesn't have it. Yeah.
But definitely, ma'am, like earlier when I did my ultrasound training, like maybe a decade or more, maybe 2 decades, like initially I thought we were told that the normal ovarian volume is 3 to 6 ml.
No,
Most of us old, but now 6 ml, 7 ml, 8 ml, all of them is considered normal.
Absolutely.
It like my teacher for my color Doppler and fetal medicine is Dr. Kuldeep Singh. So he said above 10 ml is like you consider, till 10 ml it's normal.
Absolutely.
So it's like nowadays you're not getting normal ovaries. You're getting either those large ovaries or you're getting totally invisible small ovaries. You're not getting anything normal in today's time. Yes, Sonia ma'am.
Yes, absolutely, absolutely.
And ma'am, the number of the follicles maybe at adolescent and perimenopausal PCO cases means that in perimenopausal also the numbers will definitely decrease to some amount. So
that's why we can't diagnose.
Stick to that.
That's
20
why we can't diagnose. Yeah, that is why at perimenopause it's difficult to say that this is PCOS because that structure is no longer there. And you will also notice the same thing disappearing when you're giving them insulin sensitizers. You will find big, huge ovaries over there, and as you give them, they shrink and come to normal. So that tells you that this woman is being, helped by the insulin sensitizers that you're giving. That is what does metformin do? What does
the effect of insulin sensitizers on the large ovary? Is it temporary or is it it lasts for some
temporary. It is only for a couple of months after we stop that. After that, it starts again because this is an ongoing process. PCO is not going to disappear until and unless we keep on curbing it by something or the other, either diet, exercise, or by insulin sensitizers, whatever. So, you can say from the look of the ovaries that this is a fulminant PCO. And then on the other hand, this is a very subtle, quiet, controlled PCO, where she's looked after herself. You can tell that from what you're getting on ultrasound. Yeah.
Thank you so much, ma'am.
Thank you.
And again, I take this opportunity to thank all my faculty, Foxy, Dr. Rishikesh Pai, Dr. Madhuri Patel, Dr. Alka Pandey, Dr. Priyanku Roy, my entire team of speakers, chairpersons, panelists, Dr. Sonia Malik, Dr. Sneha Bihar ma'am, and Dr. Basab for being there, Dr. Vivek Sharma for starting a program and carrying on so beautifully, being there till the end, and Intas for giving us this platform for Symbiosis Series episode 3. In December, we'll be here with another episode, Symbiosis 4, and we'll be coming with ISAR Perfection 9. So I'll be announcing the date soon. Thank you so much for your benevolent presence and always gracing the function. I'm blessed.
Thank you so much. Thank you very much.
Thank you so much, Monica, and all the best for your future endeavor in Foxy.
Thank you,
Best
ma'am.
wishes for your committee chairperson selection for perinatology committee.
Thank you so
Thank
much.
you. Thank you, Monica. Thank you, everyone.
Bye.
Bye-bye.
Good night.
Thank you so much. And I too take this opportunity to declare my candidature for Vice President Foxy for the upcoming elections. Need
All
yours.
the best, Neha ma'am.
All the best. All the best, Neha ma'am. All the best.
God bless
Thank you
you.
so much. Thank you,
We
all
are
of
there
you.
for you, and we want to see you there.
Thank
Yes.
you. Thank you so
Yes.
much.
Thank
Thank you,
you. Good
Sonia.
night.
Thank you, Sonia, ma'am. Excellent presentation. And thanks, Dr. Monica. Wonderful. This was wonderful.
Thank you so much.
Thanks, dear Nivedita.
We
Bye-bye.
can have a group photograph
Very
if you
nice
can
to
switch
meet
on your
you.
camera.
Sir,
Can you
thank
switch
you.
on your camera?
Hi,
We'll
Shweta.
have a picture. We'll have a picture. Can
Hello,
you switch
ma'am.
on your camera?
Yes.
Hi.
Do we have Dr. Anita Srivastav?
No, madam, she's not there. But
Yeah,
I'm taking
I
a
can
screenshot
see
of whoever is
her,
present. I've taken
good.
lots of pictures of individual speakers, so I'll be putting in the group. Please don't
Thank you,
exit
thank
the
you,
group.
thank you, thank you, thank you, thank
Ma'am,
you.
this is support team. Shall I stop the live streaming as it is over?
Sure, sure,
Yes,
sure,
yes,
sure.
please, please. Thank you. Good night.
Good night.
Good night,
Have a
everyone.
great
Good night.
evening. Have a great evening, and don't study anything today.
No, 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 not at all. I'm so inspired by your talks that
I'm
I've gone
not
out for a
studying
walk.
today.
I've gone out for a
Okay.
walk.
Bye-bye.
Bye.
Bye.
Bye.